Hey guys, welcome. I think you have been waiting for a while. I understand, but there was some issue in the back end, so we have rectified it right now. So I think we are good to go. Are you able to see and hear me? If you are able to see and hear me, you can give a thumbs up. Hi Roshan, good evening. Hi everyone. Good evening, good evening, good evening. Yeah, let us start the session. So the wait is over now. Sorry for the mild delay, but nevertheless, I'm going to actually discuss top 50 core topics for your upcoming FMG session. I know you have an exam recently. We have to have a kind of a very good discussion, and don't worry about it. We are going to discuss almost all of the important topics that's required for FMG exams. And trust me, I've compiled a lot of data from the last 3-year FMG exam, starting from 2020. Then I compiled data from 2021, and I compiled data from June 2022 exam as well. And I made sure that I have covered each and every topic of medicine from these 3 years. And apart from that, I think there are some other areas which are also important. Even those areas I'm going to cover. So let's move into the discussion straight away. So one of the important areas that people tend to ask in FMG exams is the determination of axis. If you look at the questions on cardiac axis, there have been almost 3 to 4 questions to be precise, okay, in the last 3 years. So that is why I thought like the first thing that I'm going to discuss will be on cardiac axis. So can anyone say what is the cardiac axis in this ECG? So before going into the discussion of how to find out cardiac axis, can you tell what is the cardiac axis in this patient? Anyone? Okay, so let me tell you what is the cardiac axis in this patient. So this is actually right axis deviation. But first of all, you need to know how to find out the cardiac axis. You have to look at leads 1 and AVF. Okay, so you have to look at 2 leads. If lead 1 is showing predominantly positive deflection, if lead AVF is also showing predominantly a positive deflection, you're going to call it as a normal axis, point number 1. If lead 1 is negative and lead AVF is also negative, it's very likely to be a northwest axis, or otherwise you can also call it as an extreme axis deviation. And I think people are asking about NEET PG versus FMG. So remember, both exams are basically coming from the same board. It's the National Board of Examinations. And the only difference between FMG and NEET PG is the type of exam that you're giving. So for example, FMG is a qualification exam, whereas NEET PG is a competitive exam. That's it. Absolutely, I don't think there's going to be any difference with the way they're going to ask questions, or I don't think there's going to be a lot of difference in the type of questions that you're going to get. So don't worry about that, okay? So if both lead 1 as well as lead AVF are negative, it's going to be northwest axis, otherwise called as extreme axis. If lead 1 is negative and lead AVF is positive, you're going to call it as right axis deviation. And if lead 1 is positive and lead AVF is predominantly negative, it could be a normal axis or it could be a left axis deviation, any one. So how to sort out the confusion? In this case, you have to look at lead 2. If the lead 2 is going to be positive, you're going to call it as normal axis. In case if the lead 2 is negative, you're going to call it as left axis deviation. So that's it. So as simple as that, okay? So let me repeat: 1 positive AVF positive, normal axis; 1 negative AVF negative, northwest or extreme axis; 1 negative AVF positive, right axis; 1 positive AVF negative, normal axis, or probably left axis deviation. How to sort out this confusion? You have to see lead 2. If lead 2 is positive, you're going to call it as normal axis. If lead 2 is negative, you're going to call it as left axis deviation. As simple as that. That's all. Okay, so that's how we determine the axis. Look at this ECG. So what the patient is having, this patient is having lead 1 negative and lead AVF is supposed to be positive in this case. Okay, lead AVF is positive in this case. So if lead 1 is negative and lead AVF is positive, it's going to be a right axis deviation. Okay, because lead 1 is negative and lead AVF is positive, it's going to be right axis deviation. Can you see? Lead 1 is negative, predominantly negative. It's a negative deflection, and lead AVF is having a predominantly positive deflection. So 1 negative, AVF positive. Remember, we are going to call it as a right axis deviation, isn't it? So this patient is actually having a right axis deviation in the ECG. So now we know how to find out axis by looking at only two leads, 1 and AVF. That's it. Okay. Now let us move on to the next important topic. Okay. So that is acute coronary syndrome management. How will you manage a patient with acute coronary syndrome? So first of all, when you talk about ACS, ACS is all about plaque rupture. Okay. So the plaque has ruptured. So because plaque has ruptured, there will be formation of a thrombus, and that thrombus will cause a new ischemia, and that is what we call it as acute coronary syndrome. And we know acute coronary syndrome is of two types. One is ST elevation myocardial infarction, that's otherwise called as a STEMI. Second one, we have non-ST segment elevation myocardial infarction and unstable angina. So we have N-STEMI unstable angina complex, right? So we have STEMI and we have N-STEMI unstable angina complex. So N-STEMI unstable angina complex together will be called as non-ST segment elevation acute coronary syndrome, otherwise called as NSTE ACS or non-ST segment elevation acute coronary syndrome. So that's how it's going to be. So two types, STEMI and second is N-STEMI unstable angina. And I don't know why people are commenting that the class is ended. I don't think the class has ended. The class is still going on. I don't know why many people are saying like it has stopped and or it has ended. I don't think it has ended or it has stopped. So are you all able to see and hear me, by the way? You are able to see and hear me, right? Class is continuing. I don't know. Many people are commenting that class is ended. Class is over. It's working. I don't know why many people are saying. Just hold on 1 second. Okay, let's get back. So I just checked with the team also, and the team also said like it is actually continuing. I don't know so why many people are commenting that the class is over. Okay, fine, all right. So we have two forms of ACS, that is acute coronary syndrome. One is going to be the STEMI, that is ST elevation myocardial infarction. The second one is going to be N-STEMI unstable angina complex, otherwise called as non-ST segment elevation acute coronary syndrome. So remember, whenever you suspect ACS, so whenever you are going to suspect acute coronary syndrome, so what do you need to do? So when will you suspect? Number one, the most important thing is the chest pain. The patient will be having chest pain, point number one. And you know how the chest pain will be? The chest pain will be crushing, or sometimes patient will tell as if somebody is standing over their chest. That's how the chest pain is going to be. And there are other important signs that the examiner might give, like diaphoresis. Patients can have diaphoresis, which is a very, very important sign. And patients can have other signs of decompensation, like pulmonary edema, which is also called as acute heart failure. And patients can also have hypotension. And patients can also have something called as ventricular tachyarrhythmias. So I always like short forms and some acronyms. Whenever I write VAs, VA stands for ventricular arrhythmias, like ventricular tachycardia or ventricular fibrillation. So whenever you have a patient with chest pain, presenting with diaphoresis or pulmonary edema or hypotension or ventricular arrhythmias, you're going to suspect ACS in exam. So whenever you suspect ACS or whenever any patient presents with chest pain to your emergency, so what is the next investigation that you're going to do? You're going to do ECG, and they will definitely ask you how fast you need to do an ECG. So you have to do within 10 minutes. I'll repeat, you have to do within 10 minutes of admission to the emergency. You have to do electrocardiogram within 10 minutes of admission to the emergency. And second thing what you do is cardiac markers. Cardiac markers, what is the most preferred cardiac marker? It's going to be the troponin. So why we prefer troponin? Because troponin is the most sensitive as well as the most specific investigation as far as the current practice is concerned. So if you are suspecting ACS or any chest pain for that matters, if you are doing a cardiac biomarker, it has to be troponin. No matter what, it has to be troponin. Point number 3. Okay, you have to do some form of imaging. Some form of imaging is extremely important. So what kind of imaging you're going to do? The most commonly done imaging as a first step is an echocardiogram, just a simple 2D echocardiogram. Depending on what is the situation in the emergency, you can push the patient to an urgent coronary angiogram or you can even do a delayed coronary angiogram. But trust me, in most of the times, STEMI means you have to do an urgent coronary angiogram and urgent PCA. So that's what you need to do. So nevertheless, how will you differentiate STEMI from an end-STEMI unstable angina complex? STEMI patients will have ST elevation and patients will have troponin positivity. Troponins also will be elevated if it's going to be a STEMI. There is no doubt about that. If it's going to be an end-STEMI, then troponins will be elevated, but the patient will not have ST segment elevation. Third, if it's going to be an unstable angina, troponins will be normal, plus at the same time there won't be any ST segment elevation. My question is whether a normal ECG rules out a ACS, acute coronary syndrome, or not. Answer is definitely no. If the patient is having a normal ECG, it does not rule out an ACS. So that is the reason why in the emergency, even if the initial ECG is normal, we keep repeating ECGs after ECGs. And this is what we refer to as serial ECGs. That's very, very important. So that's a very important question. And at the same time, we don't do only one troponin. We tend to do serial troponins. We don't just stop with one. We do serial troponins. Even if the initial troponin is normal, we don't rule out an ACS because troponins will take some time to start elevating. So that is the reason why always do a serial troponin. And they will ask you how long it will take for the troponins to rise to a detectable cutoff. It's going to take approximately 1 to 4 hours to start rising, to start increasing. And similarly, it's going to take approximately 5 to 14 days to come back to normal. If it's going to be troponin T, then it might take somewhere around 10 to 14 days to come back to normal. If it's going to be troponin I, it's going to take somewhere around 5 to 10 days to come back to normal. So if it's troponin I, it's going to take 10 to 14 days to come back to normal. If it's troponin I, it's going to take around 5 to 10 days to come back to normal. So technically speaking, it might take 1 to 4 hours to start rising. That is the reason why you need a serial troponin. Just a single normal troponin does not rule out acute coronary syndrome, which is a very, very important point to understand. Okay, so now you know what are the important investigations that you are going to do in a patient with suspected acute coronary syndrome. Now the second thing that you need to know is how to manage an acute coronary syndrome. Whenever you suspect an acute coronary syndrome, what are the things that you should do in the emergency? So that is what we call as initial management. Remember, in most of the exams in India right now, they tend to ask only the initial management. They don't really ask about when to do PCI. So what about the initial management? So we can remember by the mnemonic called as MONA-BC. So this is a very famous mnemonic right from the USMLE exams. So MONA-BC. So M stands for what? Morphine. So we don't use morphine for all patients. We use morphine only for selected patients, those who are having severe chest pain despite the use of drugs like NTG, or those who are very anxious. Only for those patients we are going to use morphine. Nowadays we don't routinely use morphine. Then O stands for oxygen. Oxygen again is a double-edged weapon. You don't use in all patients. So patients who are having severe shortness of breath or those patients who are having a low saturation of less than 90 to 92%. Only for them we use oxygen. Otherwise we don't use oxygen because sometimes oxygen can result in free radical formation that can cause more damage paradoxically. That's why we don't use oxygen in all patients. And third, N stands for nitrates. Remember, in the setting of acute coronary syndrome, it's an emergency. We use short-acting forms of nitrates like NTG. We're going to use IV NTG. But remember, what are the problems due to NTG? It can reduce the preload because NTG causes venodilatation. So it pools the blood in the periphery so that it can reduce the venous return back to the heart. So because NTG reduces preload, you need to be careful in patients who are preload sensitive. So who are the patients who are preload sensitive? Number one, anyone with hypotension, low BP. You cannot use NTG. If the patient is having cardiogenic shock, you can't use. Second, patients are having right ventricular myocardial infarction. Trust me, this is a very, very important point. Patients are having right ventricular MI. You don't use NTG or you don't use any agent that reduces the preload, including diuretic agents. Please don't use anything that reduces the preload if the patient is having right ventricular MI. So when you suspect a right ventricular MI, whenever V4R is showing ST segment elevation, if the V4R shows ST segment elevation, you suspect right ventricular MI. Okay, or in a standard 12 ECG, if the V1 is showing ST elevation and V2 is showing ST depression, you suspect right ventricular MI. So in a right ventricular MI, don't use any agent that reduces the preload because right ventricle is preload sensitive. That's a very important point. Okay, remember, left ventricle may be inotrope sensitive. They respond well to inotropes, but right ventricle is preload sensitive. It responds when you increase the preload. Right ventricle doesn't have a good musculature, so it doesn't respond to inotropes well. That's why right ventricle is preload sensitive. You have to be very careful. And A stands for antiplatelet agents. A stands for antiplatelet agents. Antiplatelets. What are the antiplatelets? So the most important drug is aspirin. What is the loading dose of aspirin? Everyone knows. Textbooks will give 162 to 325 milligram. That's the loading dose of aspirin. But in India, we use a dose of 300 milligram because in Western countries, we have 81 milligram dose. In India, we don't have 81 milligram dose. We have only 75 milligram dose. So in India, we use a dose of 300, 4 tablets of aspirin. But the most important point is please don't use entry-coated tablets of aspirin. Use immediate release tablets because this is an emergency. You don't want a preparation of aspirin that's going to be having a delayed release. Don't use the ecosprin entry-coated. Use immediate release chewable aspirin. And next, you can use a P2Y12 inhibitor. This is optional. Remember, this is optional in the setting of an NSTEMI unstable angina. P2Y12 inhibitor is almost mandatory in all patients with STEMI. But in NSTEMI unstable angina complex, P2Y12 inhibitors are optional. So what are the P2Y12 inhibitors? We have Clopidogrel, very commonly used drug in India. What is the loading dose of Clopidogrel? 300 to 600 milligram. That's the loading dose of Clopidogrel. The first dose should be 300 to 600 milligram. Later on, you can shift to 75 milligram per day dose. Second dose is Prasugrel. Prasugrel is one of the most powerful drugs. Prasugrel means power. Prasugrel means potency. P for Prasugrel, P for potency. It's a very powerful drug. Because it's a very powerful drug, the loading dose is just going to be 60 milligram. And the next drug is ticagrelor. All are basically P2Y12 inhibitors. Ticagrelor. The loading dose of ticagrelor is 180 milligram. After that, you can maintain at a dose of 90 milligram 2 times a day, but the loading dose is 180 milligram. At least remember the loading dose. Aspirin 300, Clopidogrel 300 to 600. Most commonly used drug is 300. Prasugrel 60, ticagrelor 180. At least the loading dose. So yes, as many people are telling, it's correct. Clopidogrel and Prasugrel are basically prodrugs. It needs cytochrome 2C19 to get converted to active forms, but ticagrelor is an active drug by itself. Okay, ticagrelor is an active drug. It is not a prodrug. Okay, this is all about the P2Y12 inhibitor. I'll repeat one more time. P2Y12 inhibitor is definitely required in a patient with STEMI, but it may not be required in a patient with NSTEMI unstable angina. It's only optional there, depending on the situation. And what about B? B stands for beta blockers. Repeat with me. B stands for beta blockers. B stands for beta blockers. So what beta blockers you're going to use? Preferably a cardioselective beta blocker, but you can use labetalol also if the patient is also having associated hypertension, no problem. Okay, beta blocker. But you need to know the standard beta blocker contraindications. So what are the standard beta blocker contraindications? Number one, any patient with severe COPD and bronchial asthma. Remember, it is not just COPD and bronchial asthma, severe COPD and bronchial asthma. Then only you are going to avoid beta blockers, otherwise you are going to use, especially in those with recent exacerbations. I repeat, recent exacerbations. If there is a documented recent exacerbation of COPD bronchial asthma, don't use beta blocker. It's a very important contraindication. Second important contraindication, patients who are having a PR interval of more than 0.24 seconds, or patients who are having a second degree or a third degree AV block, because beta blockers are AV nodal blockers. So I'm not going to risk in a patient who is already having a second or third degree AV block. Patients who are having bradycardia, okay, I'm not going to use beta blockers. Number 5, patients who are having hemodynamic instability, low BP, I'm not going to use beta blockers. Number 6, patients who are having acute heart failure, any heart failure signs, I'm not going to use beta blockers. I'll repeat, acute heart failure, no beta blockers, because beta blockers are negatively inotropic agents. I'm not going to use. So how will you classify whether the patient is having acute heart failure or not in the setting of MI or ACS? You use something called as KILIP score. This is a clinical score, very, very commonly asked in exams. So what are the different types of KILIP score? We have different stages of KILIP score or grades of KILIP score. We have grade 1, 2, 3 and 4 or class 1, 2, 3, 4. So what is class 1? Class 1 means patients are not having heart failure or any signs of heart failure. Like patient is not having third heart sound, patient is not having jugular venous distension, and patient is also not having any crepitations. The lungs are clear. That is what we call that KILIP class 1. What is KILIP class 2? Patient is having signs of heart failure, like third heart sound is there. Next, jugular venous distension is also there. Number 3, patient will also have crepitations, but that crepitations will be limited to the base of the lungs. I'll repeat, it will be limited to base of the lungs, not the entire lung fields. What about class 3? Here the patient will have severe heart failure. Severe heart failure, which means here the patient is having frank pulmonary edema. What do you mean by pulmonary edema? What is the difference? Patients are not only having crepitations in the base, patients are having crepitations throughout the lung fields. Okay, that is pulmonary edema, frank pulmonary edema. Class 4, patients are having shock, cardiogenic shock, low BP. That's the worst that you can ever have. Patient is having a cardiogenic shock because of MI. That's KILIP class 4. Okay, anyone who is KILIP class 2 and above, I'm not going to use beta blockers. I'll repeat, anyone who's having a KILIP class 2 and above, which means if there are any signs and symptom of heart failure clinically, I'm not going to use beta blocker. Which means to use beta blocker, patient should be in KILIP class 1. Okay. So what are the contraindications for beta blockers? Severe COPD bronchial asthma, especially in those with recent exacerbations. PR interval more than 0.24 seconds. Second or third degree AV block. Bradycardia, hypotension, acute heart failure, which means KILIP class 2 and above. And what about C? C stands for anticoagulants, which is very commonly used in the setting of an acute coronary syndrome. Anticoagulation. So what anticoagulations are available? In the setting of ACS, we are not going to use oral drugs like warfarin. Then you are going to use only parenteral drugs. So what parenteral drugs you can use? Number 1, unfractionated heparin can be used. Second, low molecular weight heparin can be used. Number 3, fondaparinux can be used. Number 4, you can use bivalirudin. Okay, so these are the 4 drugs that are approved to be used in patients with acute coronary syndrome. Many people are telling rivaroxaban, dabigatran and all. But remember, rivaroxaban, dabigatran are basically oral drugs. You're not going to use oral drugs in the setting of emergencies like ACS. The most commonly used drug will be unfractionated heparin and low molecular heparin. Very commonly we use enoxaparin in practice. Fondaparinux and bivalirudin are very rarely used drugs. We don't use fondaparinux and bivalirudin that often. In that, bivalirudin should be given as continuous IV infusion. So it will be usually given inside the cath lab. Okay, many times when you can't give any other anticoagulation, and if it's an urgency inside the cath lab, you can give it as a continuous infusion. For that only you are going to use bivalirudin. Otherwise, I'm not going to use bivalirudin. Okay, so this is how I'm going to manage acute coronary syndrome. Are you able to understand whatever I told you? How to manage ACS? First, how to diagnose? 3 means ECG, markers, imaging. Then, what is the difference between STEMI, NSTEMI, unstable angina? Then, what is the initial management? That is MONA-BC. Most of the questions in your exams will be based on initial management only. Nothing more than that. So, you need to definitely proceed with reperfusion. There is no doubt about that. You need to surely proceed with reperfusion. But how to perform reperfusion is something that you won't really get as a question as much as possible. I mean, that much in exams. Okay. So, what are the techniques of reperfusion? So, quickly. So, somebody is repeating the question. I'll come back to that. Okay, Dr. Akhil Raj, I'll come back to that. So, what are the techniques of reperfusion? We have 2 techniques of reperfusion. One is thrombolysis. Second is going to be a PPCA, that is primary PCA. These are 2 techniques that you're going to try for STEMI patients. Okay. But one thing that you need to know is thrombolysis should not be used in a patient with NSTEMI. Okay, if the patient is having an NSTEMI unstable angina complex, you should not use thrombolysis as a reperfusion strategy. You should use only PCA or cabbage. So, no thrombolysis in NSTEMI unstable angina. So, write it down. No thrombolysis in NSTEMI unstable angina. No thrombolysis in NSTEMI unstable angina. No thrombolysis in NSTEMI unstable angina. That's all. You can't use thrombolysis. You can use a PCA, or sometimes in emergency situations we need to even proceed with the coronary artery bypass grafting. But no thrombolysis in a patient with NSTEMI. And one more important thing that you need to notice for exams, I can teach you, but this is a revision session, so I don't want to go into details of that. So that is the reason I'm not talking about the contraindications of thrombolysis in a patient with ACS. But it's your duty to learn about the contraindication to thrombolysis in ACS as well. So look at this ECG. This ECG is showing a ST elevation MI or a non-ST segment elevation MI. So what are you seeing here in this ECG? ST elevation MI or a non-ST segment elevation MI. What are you seeing? Okay. So it's a clear-cut STEMI. That is what you're seeing here. It's a clear-cut ST elevation myocardial infarction. Okay. So what you're seeing here is a nice convex ST segment elevation that is seen in leads V2. You are seeing it in lead V3. You are seeing it in lead V4. You are seeing it in lead V5 and a little bit in lead V6 also. And you are also able to see a little bit in lead 1 and a little bit in lead AVL as well. Okay, so this is a clear-cut ST segment elevation myocardial infarction. There is no doubt. And because the patient is having ST elevations in V2 to V5 especially, this must be an anterior MI. This must be an anterior myocardial infarction. So whenever you talk about anterior MI, the culprit artery must be left anterior descending artery only. The culprit artery must be LAD. Whenever you talk about an anterior MI, the culprit artery must be LAD, that is left anterior descending artery. So anyway, at your level, okay, in exams, what they are going to ask is whether it is a STEMI or a NSTEMI. That is more than enough. This patient is having a clear-cut STEMI. Okay. So whenever the patient is having a STEMI, I told you, ideally within 2 hours, you have to take the patient for some sort of reperfusion strategy within 2 hours. So reperfusion will be the next important therapy after that initial treatment, and this reperfusion can be thrombolysis or it can be PPCA. But remember, primary PCA is the one that is almost always preferred. But in case if you cannot do primary PCI, which means if you think that the primary PCI will be delayed, then in that situation you can do thrombolysis. Okay, in case if you think that primary PCI will be delayed, then in that situation you can do thrombolysis. That's all. If it's going to be N-STEMI unstable angina complex, I'm never going to do thrombolysis. Either it's PCI or a coronary artery bypass grafting. That's it. Okay. Now coming to the next important topic. Yeah, the window period for thrombolysis is going to be 12 hours. There is no doubt about that. But it depends again. So there are so many other guidelines that are involved in that, but it's very unlikely that you're going to get a question on when to do thrombolysis or when to do PCI and all those things. It's a detailed discussion. Right now we'll leave it off. And coming to the management of bradyarrhythmias. Remember in exams again, they will concentrate more on the management rather than the diagnosis. They might ask you the diagnosis also, but nowadays it's a common practice that in a NB based exam, they target mostly the management part. So first of all, what arrhythmia it is? So there is some bradyarrhythmia going on because you all know that whenever the gap between two QRS is more than 5 large boxes, it is definitely a bradyarrhythmia. So here 1, 2, 3, 4, 5 large boxes and more than that is there. So definitely I can assume that this patient is having some sort of bradyarrhythmia without a doubt. So specifically what bradyarrhythmia that this patient is having. If you look at carefully in the lead 2, this patient is having 2 P waves, okay, both of which are conducted. Okay, the patient is having 2 P waves, both of which are conducted into QRS, but there is another P wave following that 2 QRS complexes which is not conducted. This is a blocked beat. So whenever you see a blocked P wave like this, you always suspect MOBITS. Whenever you see a blocked P wave like this, you always suspect a MOBITS. And if you want to know if it is MOBITS 1 or MOBITS 2, you look at the PR interval. Look at the PR interval. You have to know whether the PR interval is varying or PR interval is constant. So look at the PR interval. The PR interval in this case is constant. It is not varying. Everyone would have agreed. So this is a MOBITS type 2 block. Remember, MOBITS 1 only is called as Wenckebach. MOBITS 2 is not called as Wenckebach. MOBITS 2 is the diagnosis in this ECG. Okay. So there is a missed beat, which means P waves are there, but QRS is not there, which means it's a blocked P wave. Plus at the same time, the PR interval is constant. It is not varying. If it's varying only, it's MOBITS 1. If it's not varying and it's constant, it is MOBITS 2. The right answer for this ECG is MOBITS 2, type 2 block. And remember, MOBITS 2 is the one that is dangerous. If they ask you whether MOBITS 1 versus MOBITS 2, which is dangerous, always trust me, MOBITS 2 is the one that is more dangerous. Because most of the patients with MOBITS 2 will be hemodynamically unstable. And most of the times in patients with MOBITS 2 block, there is a high chance of getting converted to a complete heart block. There's a high chance that the MOBITS 2 can get converted to a complete heart block. That's why MOBITS 2 is more dangerous than MOBITS 1 block. And is this the diagnosis? MOBITS 2 here? Yes, that is the diagnosis, but there are plenty of other possibilities here. Other diagnosis that is hidden in the ECG. Look at lead V1. Look at lead V1. In the lead V1, you are seeing right bundle branch block pattern. And are you seeing only RBB pattern? No, you are seeing something else. You are seeing ST elevation, man. Okay, you are seeing ST elevation here. Just hold on. Sorry guys, I think I had a very important call so that I have to pause a little bit. But nevertheless, so what is happening here? So this patient is having a ST elevation. So which means this patient is having a STEMI. Okay, this patient is having a ST elevation myocardial infarction. Along with that, that STEMI is causing a right bundle branch block. And it's not only causing a right bundle branch block, this patient is also having a Mobitz type 2 block. So the final diagnosis in this case is not just a Mobitz 2. This is a STEMI, acute STEMI, and anterior STEMI due to LAD occlusion, causing a right bundle branch block, and at the same time causing a Mobitz type 2 block also. That's the final diagnosis of this ECG. Okay. So be very clear about that. That's it. It's done. Okay. So how will you manage bradyarrhythmias now? So acute management of bradyarrhythmias is a very common question in exam. So number one, whenever a patient is presenting with bradyarrhythmia, you have to see where the patient is hemodynamically unstable or not. Stable or unstable. So that's what you need to look at, the next step. If the patient is stable, if it's an acute bradyarrhythmia, just observe the patient. That's all. Nothing more than that is required. Just observe the patient. If the patient is not stable, if the patient is unstable, then what are you going to do? You are going to do some intervention, management. The immediate management will be atropine. You are going to immediately give atropine. Immediate management will be atropine. So what is the dose of atropine? According to ACLS protocol, it is 0.5 milligram atropine. That's the first dose. And you can give a total maximum of approximately 3 milligram. You can give a total maximum of approximately 3 milligram. Somebody is asking how to find out right bundle branch block. I'll show the right bundle branch block ECG in a while. So this is the maximum dose of atropine, that is 3 milligram. So in case if the patient is not responding to atropine, the next step will be to go for a pacemaker. So what the guidelines are saying, initially you can try a transcutaneous pacemaker. Then you can convert this transcutaneous pacemaker into a transvenous pacemaker. You can convert the transcutaneous pacemaker into a transvenous pacemaker once the expert is available. But initially first you are going to try a transcutaneous pacemaker. In case pacemakers are not available at that point of time, alternative to pacing will be your chronotropic drugs. Like you can use either dopamine or adrenaline. You can use dopamine or adrenaline. These are chronotropic drugs. This is an alternative to pacing. So let me repeat. If you are dealing with an acute onset bradyarrhythmia, see the stability. If the patient is stable, observe. If the patient is not stable, give atropine. If the atropine is not working, go for pacemaker. The first step will be a transcutaneous pacemaker. Once the expert is available, go for a transvenous pacemaker. And the alternative to temporary pacing will be dopamine, adrenaline, which are nothing but chronotropic drugs that increase the heart rate. And what do you mean by the term stability? Stability means you are going to look at the systolic blood pressure. If the systolic blood pressure is less than 90, then it indicates that the patient is unstable. Okay, systolic BP less than 90, unstable. If the patient is presenting with syncope, you can say that the patient is unstable. If the patient is having acute heart failure like pulmonary edema, you can say that the patient is unstable. Or the patient is presenting with chest pain suggesting myocardial infarction, you can say that the patient is unstable. But in exam, the most commonly tested area is systolic BP of less than 90, which is a very, very important and a hallmark sign of instability in the setting of any bradyarrhythmia or even a tachyarrhythmia. Okay, that's it. So adenosine, so somebody is asking noradrenaline. Okay, definitely not noradrenaline, because noradrenaline is not very good in increasing the heart rate. It is very good in increasing the mean arterial pressure, but noradrenaline is not a good drug that increases the heart rate. Even though in practice we don't see the heart rate reducing effect of noradrenaline, even though that's given in pharmacology textbooks, generally noradrenaline is not a very good drug that increases the heart rate. That is something that you have to keep in mind. Okay, now going to the management of tachyarrhythmia. So I'll talk about the management of tachyarrhythmia in a while, but let us diagnose 4 important ECGs for your exam. So what is this ECG? This is a very, very common ECG in your exam. So what is this? This patient is surely having a tachyarrhythmia. How can I say it is tachycardia? Because if you have less than 3 large boxes between 2 QRS complexes, which means it's a tachycardia. That's what you need to know. More than 5 large boxes, bradycardia. Less than 3 large boxes, tachycardia. Here the patient is having definitely less than 3 large boxes only. So it's surely a tachycardia. And it's an irregular rhythm. We all know that. It's an irregular rhythm. And at the same time, you are not able to see any formed P waves. The baseline is just fibrillating. You are not able to see any formed P waves at all. So this is a case of atrial fibrillation, AF. Very, very common rhythm in your exam. In fact, if you take sinus tachycardia from your tachyarrhythmia diagnosis, AF remains the most common arrhythmia. In the ICUs or anywhere, if you see AF is the most common tachyarrhythmia, if you remove sinus tachycardia from the arrhythmia algorithm. Okay, so this is an atrial fibrillation. Then, what about this rhythm? So here is a rhythm, which is again a narrow complex tachycardia. Okay, this is a narrow complex tachycardia, there is no doubt about that. But it's a regular rhythm. It's a regular rhythm. It's a regular rhythm. It's not an irregular rhythm. So this is a regular narrow complex tachycardia, but you're not seeing any P waves before the QRS. So this is the QRS, this is the T, but you're not able to see the P. So what is this rhythm? So remember, PSVT is the old term. We don't use the term PSVT anymore because honestly speaking, anything that is not a VT is SVT. Everyone knows that. Okay, technically atrial fibrillation is also an SVT only. So don't use the term PSVT. Rather, this is very likely an AVNRT or probably an AVRT with orthodromic conduction, but this is actually an AVNRT, that is AV nodal reentrant tachycardia. So why it is an AV nodal reentrant tachycardia? Because you are able to see the P wave that is buried within the QRS. You can see the P wave that is buried within the QRS like a small notch over here. This is what we refer to as something called a pseudo S pattern, pseudo S pattern. And similarly, in the V1 also, you will be able to see the P wave that will be buried within the QRS complex. This looks like a R wave, so that's why this is also called a pseudo R wave or pseudo R pattern, which is also a sign of AVNRT. So this patient is having a AV nodal reentrant tachycardia. That's all. So what about this? So this is a spotter. Just look at it and tell that this is a ventricular tachycardia. These kind of common questions only you get in exam. So this is a wide complex tachycardia beating at a rate of almost 300. What else it's going to be? It's a ventricular tachycardia, but it's a monomorphic ventricular tachycardia or a polymorphic ventricular tachycardia. Remember, this is a monomorphic ventricular tachycardia. Why it is a monomorphic ventricular tachycardia? Because the complexes are having a single morphology. Complexes are having a single morphology. They don't change their morphology. That's why it is called as a monomorphic ventricular tachycardia. And come back to the next rhythm. Look at this one. So this is a polymorphic ventricular tachycardia. So none of you will have doubt that this is a VT or not. Definitely this is a ventricular tachycardia, but monomorphic or polymorphic? This is the polymorphic ventricular tachycardia. So why polymorphic? Because the complexes are different. So look at the complexes. The QRS complexes are looking different from each other. They are not the same. They are not having single morphology. So this is a polymorphic ventricular tachycardia. Remember, whenever the patient is having a polymorphic ventricular tachycardia and if the patient is having a long QT syndrome, we are going to make a diagnosis of torsade pointer, TDP. We are going to make a diagnosis of torsades. So when we call it as TDP, repeat with me, if you have a polymorphic ventricular tachycardia, along with that if you have a long QT syndrome, you are going to call it as torsades. So this patient is having a long QT. Yes. How can I say that this patient is having a long QT? Look at this strip. This patient was initially having a sinus rhythm. Later on, he developed tachyarrhythmia. Fortunately, the strip was recorded before the arrhythmia. So how will you calculate QT? You see the QT is going to be somewhere from here to here. This is the QT interval. So you include the QRS complex and the T wave. Okay. So QT interval. And you calculate the RR interval. Okay. You calculate the RR interval. Technically, if the QT interval is more than half of the RR interval, I'll repeat, if the QT interval, grossly what you are visualizing, the QT interval, if it's more than half of the RR interval, it is very likely to be a long QT. Okay, this is a trick in exam that you can follow. If the QT interval is more than half of the RR interval, that is long QT. Remember, ideally speaking, you need to look at a value called QTC. Remember, the normal QTC is less than 0.44 seconds or 440 milliseconds in a male and less than 0.46 seconds or 460 milliseconds in a female. Only if it exceeds this value, you are going to call it as long QT. But remember, you have to calculate something called corrected QT. That's called QTC. How will you calculate corrected QT? You are going to use a formula called as Besset's formula. So what is Besset's formula? QT divided by square root of RR interval. So that is what we call it as Besset's formula. QT divided by square root of R interval. That's what we call it as Besset's formula. So you need not do that. Okay. The computer will take care. The machine will take care. That is going to give the QTC value. But in case the examiner has not given the QTC value, okay, then you can use this trick which I have told you. The QT that you are seeing is more than half of the RR interval. You can call it as long QT. So what is the most common cause of long QT right now in the world? The most common cause of long QT is the drugs. Drugs are the most common cause of long QT right now in the world. And second most common cause is electrolyte imbalances. So in exam, most of the time they're going to target the electrolyte imbalances. So somebody is asking how QT is different from QTC. Remember, corrected QT means you are correcting the QT based on the RR interval, because QT can change based on the heart rate, isn't it? If you have a bradycardia, QT will be long. If you have a tachycardia, QT will be short. So we cannot remember a QT value for each and every heart rate. That is why we want to have a universal standard. That is the reason why we are having a concept called corrected QT. Okay, so that's the reason. So we are correcting the QT based on the RR interval. So the most common cause are the drugs. The second most common cause is electrolyte changes. So what are the drugs? There are plenty of drugs, right? From antipsychotics, antihistaminics, antibiotics. What antibiotics? Macrolides, like erythromycin, azithromycin, clarithromycin, and quinolone drugs. Quinolones, Q, long QT. I'll repeat, quinolones, Q, long QT. Okay? For example, levofloxacin, moxifloxacin, they can cause long QT. And there's a drug called bedaquiline, anti-tubercular drug that can be asked in exams. Bedaquiline, Q, long QT. So remember, quinolones, okay, Q, long QT. Bedaquiline, Q, long QT. Okay, and azoles, antifungal drugs. They can also cause long QT. You can remember fluconazole. You can remember as fluconazole. Instead of C, you can remember Q, fluconazole. Azoles can cause long QT. And antiarrhythmic drugs can cause long QT. There are two classes of antiarrhythmic drugs that cause long QT. One is class 1A and second is class 3. Okay, class 1A drugs and class 3 drugs also can cause long QT. I'll repeat, class 1A and class 3 drugs can cause long QT. There are plenty of drugs. Some of the important drugs: antibiotics, antifungals like azoles, anti-tubercular drugs like bedaquiline, anti-arrhythmic drugs like class 1A, class 1-3 drugs, class 3 and class 1A drugs, and antihistaminics and antipsychotics. Okay, these are the drugs that cause long QT. And what are the electrolyte imbalances that can cause long QT? Hypokalemia, hypocalcemia, and sometimes even hypermagnesemia, and hypothermia. Hypothermia is not an electrolyte problem, but it's a metabolic problem that can cause long QT. So all the hypos, remember the hypos: hypokalemia, hypocalcemia, hypomagnesemia, hypothermia. Okay, hypos can cause long QT. That hypocalcemia is a $1 million question in exam. They will ask you all of the following are true except with regards to hypocalcemia. One of the options will be short QT. That's wrong, because hypocalcemia produces long QT, not short QT. Okay, that's it. So we have discussed a little bit about QT interval also. Now let us move on to the management of tachyarrhythmia as such. I'm going to talk about the ACLS protocol. ACLS protocol for management of tachyarrhythmia with a pulse. So how will you manage a patient with tachyarrhythmia and having a pulse? So step number 1, always rule out sinus tachycardia. Step number 1, always rule out sinus tachycardia before starting the treatment, because treatment of sinus tachycardia in most cases is treatment of cause. Okay. So once you have ruled out sinus tachycardia, next step is to see whether the patient is stable or unstable. Stable or unstable. If the patient is not stable, which means if the systolic BP is less than 90, for example, you have to proceed with something called synchronized DC cardioversion. Synchronized DC cardioversion. If the patient is going to be stable, yes, then you can try drugs and other maneuvers. For that, you need to see the QRS width. Okay, you need to see the QRS width. If the QRS width is less than 0.12 seconds, you're going to call it as narrow complex tachycardia. If the QRS width is more than 0.12 seconds, you're going to call it as wide complex tachycardia. Okay, wide complex tachycardia. If the patient is having narrow complex tachycardia, see whether the patient is having a regular rhythm or whether the patient is having a irregular rhythm. If the patient is having regular rhythm, the next step is to try vagal maneuvers. Guidelines say that you have to try vagal maneuvers. So vagal maneuvers like Valsalva or vagal maneuvers like carotid sinus massage. What are you going to do? Gently press the carotid sinus, or do some other vagal maneuvers like Valsalva, which is nothing but a straining maneuver. Okay. If the vagal maneuvers fail, if the patient doesn't respond to vagal maneuvers, you can try adenosine. Adenosine. The standard protocol for adenosine is 6 plus 12 plus 12. So even this has been asked in exam. 6 milligram is the first dose of adenosine. 6 plus 12 plus 12. In case of irregular tachycardia, irregular narrow complex tachycardia, try AV nodal blockers. Try AV nodal blockers. So what AV nodal blockers you can try apart from adenosine? You can try beta blockers. Beta blockers, or you can try non-dihydropyridine calcium channel blockers like verapamil or diltiazem. NDHPs means we are talking about non-dihydropyridine calcium channel blockers like verapamil or diltiazem. Verapamil or diltiazem. Clear? So regular vagal maneuvers followed by adenosine. Irregular, you try beta blockers or non-dihydropyridine calcium channel blockers like verapamil or diltiazem. So one important golden point I can say is, in irregular narrow complex tachycardia or any irregular tachycardia, don't use adenosine. It's contraindicated. I'll repeat, any irregular tachycardia, don't use adenosine. Don't use adenosine in irregular tachycardia. If it's irregular, forget adenosine. What about wide complex tachycardia? If it's a wide complex tachycardia, guidelines suggest you to use antiarrhythmic drug infusions. What are the antiarrhythmic drug infusions that you can use? You can use amiodarone, which is one of the commonest drugs that is used in practice, or you can use procainamide, or even you can use something called as sotalol. These are the 3 drugs that guidelines are recommending. But specifically, if they have mentioned torsades, if they mention torsades or they're given an ECG of a torsades, then you can try something called as magnesium sulfate, MagSulf. I'll repeat. If it's not a torsades, you can try amiodarone, procainamide, or sotalol. Okay, if it is a torsades, the answer will be IV MagSulf, magnesium sulfate. Okay, so everyone clear about this algorithm, because this is a very, very important practical algorithm asked in almost any exam in the country right now. So leave alone the FMG. They can ask in NEET PG, they can ask in INACT, anywhere, because this is an emergency. Okay, it's very, very important. Okay, now let us move on to the next topic. I want to show some special ECGs. So what are the important and special ECGs that I want to show? One is left bundle branch block. The first one. So how will you diagnose a left bundle branch block? Number 1. Patients who are having wide QRS. Number 1. Along with that, in V1, if you see a predominantly negative deflection, if you see a predominant negative deflection like this, if you see a negative deflection in V1, along with the wide QRS in V1, okay, that is equivalent to left bundle branch block pattern or left bundle branch block morphology. That's it. So this is the simplest and the most easiest way to diagnose a left bundle branch block pattern and morphology. Look at this one. Here, the patient is having a RSR pattern. A patient is having RSR pattern. Along with that, if you see a wide QRS, okay, that is equivalent to a RBBB pattern, right bundle branch block pattern or right bundle branch block morphology. So if you see a predominantly positive complex in V1, okay, or a typical M pattern, okay, otherwise called as M pattern or RSR pattern, that is equivalent to right bundle branch block morphology or right bundle branch block pattern. That's it. Okay, see the difference? Predominantly negative complex with wide QRS, LBBB morphology or LBBB pattern. Predominantly positive complex in V1 or a M pattern in V1 or a RSR pattern in V1 with wide QRS, right bundle branch block morphology. That's it. It's done. What are the other 2 important special ECGs I want to show? These are the important ECGs that can cause sudden death in individuals, especially young individuals. Look at ECG number 1. This is an ECG of arrhythmogenic right ventricular cardiomyopathy or ARVC. So what you tend to see in ARVC? You are going to see something called as epsilon waves. So what are epsilon waves? Epsilon waves are basically J waves. Epsilon waves are basically J waves. J waves means you are going to see waveforms at the J point. At the J point, what you're seeing small wavelet-like appearance. I think everyone can see. You can see small wavelet-like appearance in the J point in V1. That is nothing but epsilon wave. Whenever you see this epsilon wave, it is very much suggestive of arrhythmogenic right ventricular cardiomyopathy, which is a very important reason for sudden death in European population right now in young individuals. And that's not the only sign. You will see evidence of RV dysfunction. What are the evidence of RV dysfunction? You're going to see T wave inversions, okay, in anterior leads like V1, V2, V3, V4, and it can progress beyond V4 and can enter V5 also. In Europe, any young individual with T wave inversions beyond V3 or V4, they are going to diagnose ARVC unless proved otherwise. In African Americans, that's not the case. In Asians, it's not the case. But in Caucasian race, in Europe, anyone with T wave inversions beyond V3, for them it is ARVC unless proved otherwise in the ECG. And together, if you see epsilon waves, you can confirm it is ARVC only. If they ask you the investigation of choice, it is going to be cardiac MRI. Cardiac MRI is the investigation of choice. And if they ask you treatment of choice, it is going to be ICD, that is implantable cardioverter defibrillator, because this patient is going to die because of ventricular tachyarrhythmias. T-wave inversion doesn't mean only ischemia, Dr. Soumya. T-wave inversion is very non-specific finding and it can be seen in many conditions, okay, not just in ischemia. And look at this patient. So what this patient is having? This patient is having Brugada syndrome. This is a Brugada ECG. This is a Brugada ECG. So what do you see in Brugada? You're going to see the characteristic pattern. So remember, I don't know how to explain this, but this is something that you have to just picturize in your brain. Just take a screenshot, snapshot in your eyes and just keep it in your brain. So this is something that's very, very important. So how will you identify Brugada pattern ECG? You're going to see something called pseudo RBBB pattern, pseudo right bundle branch block pattern, pseudo right bundle branch block pattern. Okay, that's not a true RBBB. You're going to see a pseudo RBBB pattern, okay, like this. Along with that, you will have ST elevation. Okay, you can see the ST elevation. Along with that, there will be coving of the ST segment, and plus or minus T wave inversion. So this you will typically see in V1 plus or minus V2. That is what we call it as Brugada pattern. That's what we call it as Brugada pattern. You will see in V1, V2 plus or minus V3. I'll repeat pseudo right bundle branch block pattern with ST segment elevation and coving with T wave inversion. Brugada pattern. Classic. So Brugada syndrome is most commonly, it is due to many gene mutations. It can occur due to multiple gene mutations, but most commonly it is due to SCN5A gene mutations. Most commonly it is due to SCN5A gene mutation. And it is autosomal dominant in inheritance. And it typically affects the males. For some reason, it is going to affect the males predominantly compared to females. And the classic feature of Brugada syndrome is it can cause sudden death at rest. It can cause sudden death at rest. In fact, I tend to tell the students that this is the true definition of something called as rest in peace. True definition of RIP, rest in peace. Because it's going to cause something called sudden death at rest or during sleep itself. Okay? And what is the treatment of choice for Brugada syndrome? Treatment of choice for Brugada syndrome is again ICD, implantable cardioverter defibrillator, because the patient is at risk of death. Okay? Treatment of choice is ICD. Investigation only ECG, nothing more than that. It's not a structural disease. You cannot diagnose by imaging. So, investigation of choice is ICD, implantable cardioverter defibrillator. Okay. Now coming to the important cause of sudden death. So what are the important causes of sudden death? So you have hypertrophic cardiomyopathy, you have arrhythmogenic right ventricular cardiomyopathy, that is ARVC. Then you have long QT syndrome, that is congenital long QT syndrome. Then we have something called as Brugada syndrome. And we have another variety called as catecholaminergic polymorphic ventricular tachycardia, that is called CPVT. I'll repeat, catecholaminergic polymorphic ventricular tachycardia. Simply you can remember as CPVT. So what about HCM? Remember, HCM is a structural problem. I'll repeat, HCM is a structural problem. There is a structural problem in the heart. ARVC is also a structural problem. ARVC is also a structural problem in the heart. Okay? There is fibrofatty replacement of some areas in the right ventricle. It's a structural problem in the heart. Long QT syndrome is not a structural problem. Rather, long QT syndrome is a channelopathy. Channelopathy. Brugada syndrome is also a channelopathy. It's some sodium or potassium channel problem. CPVT is also a channelopathy. Okay, which means it's going to be due to some sodium or calcium channel problem. Okay, and most of these problems have a strong genetic basis. So what is the genetic basis? Hypertrophic cardiomyopathy is going to be due to mutations in certain sarcomeric genes. Sarcomeric gene mutations. Okay, sarcomeric gene mutations. So what are the two important sarcomeric gene mutations that occur in HCM? One is MOH7. MOH7, that's called as beta myosin heavy chain. MOH7 gene is going to generate a protein called as beta myosin heavy chain. And we have CMYBPC, that's called as cardiac myosin binding protein C. I'll repeat, that is called as cardiac myosin binding protein C. So these two gene mutations alone contribute to 70% plus cases of HCM. I'll repeat, these two alone contribute to 70% plus case of HCM. And ARVC is basically due to desmosomal mutations. Okay, predominantly both are autosomal dominant disorders. And again, I'll repeat, ARVC is due to desmosomal mutations, which are nothing but cell-to-cell adhesion molecule, adhesion things. Okay, desmosomes. It could be desmoplakin, desmoglein, something like that. So it could be mutated. Long QT syndrome is not a structural problem. It is a channelopathy, we know that. So what is the gene mutation? Could be sodium channel, potassium channel, or even a calcium channel mutation. But most commonly, you are going to have potassium channel mutation. Okay, most commonly potassium channel mutation. Brugada syndrome is also due to some problem due to sodium channel or potassium calcium channels, but most often it is due to SCN5A gene mutations. And CPVT, catecholaminergic polymorphic ventricular tachycardia. So what's occurring here? Here it's due to calcium channel mutations. Calcium channel mutations. There are two channels that can be mutated. One is ryanodine receptor mutations, or it could be due to calsequestrin mutations. It could be due to ryanodine receptor mutation or calsequestrin mutation. Ryanodine receptor mutations are autosomal dominant, calsequestrin mutations are autosomal recessive. And we also know that Brugada syndrome is autosomal dominant and long QT syndrome also predominantly autosomal dominant. Some syndromes are there which is autosomal recessive, like your Jervell-Lange-Nielsen syndrome, but majority of the long QT syndromes will be autosomal dominant. Okay, that's it. So will there be ECG changes in HOCM? Yes, you will have ECG changes, definitely. What you will see in ECG? You will see left ventricular hypertrophy, you will see septal hypertrophy, okay, you will see septal hypertrophy and so on. So left ventricular hypertrophy and septal hypertrophy. And ECG changes in ARVC? Yes, you will see ECG changes. We discussed already. You are going to see epsilon waves, you are going to see T wave inversion, something we've seen already. And what about LQ2S? In LQ2S also you will see ECG changes where you will see long QT. Okay, that's what you're going to see in LQ2S. What you will see in patients with Brugada syndrome? In Brugada syndrome patients, you will see the characteristic pseudo right bundle branch block. Okay, pseudo right bundle branch block. Along with that, you will see ST segment elevation and you will see coving of the ST segment along with the T wave inversion. And what you will see in CPVT? Normal ECG. Okay, so that's a very, very important point. You're going to see a normal ECG in CPVT. Okay, then what about imaging? For example, you do some echo or MRI or something like that. So do some imaging modality. Let us do an echocardiogram. So what will be the finding in echocardiogram? In HCM, obviously you will see LVH and septal hypertrophy, but in echocardiogram, the most important finding that's very commonly asked in exams is the SAM of AML. I think many of you would have known about this already. That's called systolic anterior motion of anterior mitral leaflet. Very, very important finding in HCM, in echocardiogram. And what is the finding you will see in imaging in patients with ARVC? You will see right ventricular dysfunction, RV dysfunction. Okay, you can see RV dysfunction. And what is the echo finding in Brugada syndrome? Normal. In CPVT, normal. In long QT syndrome, normal. Because these are channelopathies. These are not structural problems. Remember, ARVC and HCM are structural problems, whereas LQ2S, Brugada and CPVT are basically channelopathies. Because they are channelopathies, imaging will be normal. There won't be any structural heart disease. So whenever in exam a young patient dies due to like some exertion or something like that, and if they have normal baseline ECG and normal echo, your diagnosis is going to be CPVT, very commonly asked in exams. Okay, normal ECG, normal echo, young patient, exertional death, CPVT. Don't diagnose anything else. Don't come and say it is HCM. Clear? So that's a very, very important point. So when it causes death, remember HCM, ARVC technically causes death during exertion, right? Death during exertion. Death during exertion. Similarly, CPVT also is going to cause death during exertion. Death during exertion. That's why it's called catecholinergic polymorphic VT. Brugada syndrome, we know very clearly it's going to cause death at rest or during sleep. And long QT syndrome varies. We have three types of long QT syndrome: LQTS type 1, LQTS type 2, LQTS type 3. So LQTS type 1 is going to cause death during swimming or diving. Okay, swimming or diving. Swimming or diving. LQTS type 2 is going to cause death whenever the patient hears a loud noise. I think every one of you would have seen a South Indian movie called as Vikram. It was acted upon by Kamal Haasan. It was a blockbuster in South India. And in Hindi also it's released, I guess. So you would have seen that movie called Vikram, where there will be a child. If you have seen that movie, that child is actually supposed to be suffering from LQTS type 2, because they clearly say that that child is going to die because of loud noise. Okay, so that is basically LQTS type 2. They die because of loud noise, because whenever they hear the loud noise, they get ventricular arrhythmias and they die. That's why in LQTS type 2, we generally ask the the child's parents to avoid loud alarms also. We don't keep alarms for them. Okay, what about LQTS type 3? LQTS type 3 is similar to Brugada, and they can die at rest or during sleep itself. Like Brugada, LQTS type 3 patients can die at rest. So type 1 swimming, diving, type 2 loud noise, type 3 rest, sleep. Okay, simple, that's all. So now you can see, isn't it? Most of these disorders will be treated with ICD, that is implantable cardioverter defibrillator, because you have to prevent sudden death. And what are the pointers in HCM in exam? In HCM, apart from whatever I've told you, they will give something called as pulsus bisferience. Okay, pulsus bisferience, pulsus bisferience. I'll repeat, pulsus bisferience. That's a very, very important point. Okay, in exam, HCM can produce pulsus bisferience. It's a double peaking pulse in systole. Apart from that, HCM also tend to produce dynamic changes. Okay, dynamic changes. Or they will also give something called as dynamic obstruction. So, what dynamic changes HCM is going to produce? So, it's going to change based on the load and the contractility. So, if you're going to reduce the preload, the obstruction will increase. The obstruction will increase. If you're going to increase the preload, the obstruction will decrease. If you're going to reduce the afterload, okay, obstruction will increase. If you're going to increase the afterload, obstruction will reduce. Obstruction will reduce. So you can clearly see that the arrows are moving in the opposite directions. Okay, arrows are moving in the opposite directions. That is why don't remember HOCM as hypertrophic obstructive cardiomyopathy. Remember HOCM as hypertrophic opposite cardiomyopathy. Because when preload or afterload decreases, obstruction increases. Preload afterload increases, obstruction decreases. So remember as hypertrophic opposite cardiomyopathy. I think you can get it. So what are the conditions that reduce the preload, that can increase the obstruction and probably reduce the preload and increase the obstruction, increase the murmur? So number one, most important, is the Valsalva. Valsalva is a very strong maneuver that can reduce the preload. Second, okay, think about standing. Okay, that's a maneuver called squat to stand maneuver that can reduce the preload. What can increase the preload? There is a maneuver called leg raising maneuver. Okay, leg raising maneuver that can increase the preload. Or if you give a fluid bolus, that also will increase the preload. Another thing that increases the preload is squatting, because squatting squeezes the peripheral veins. So push the blood back into the central circulation. And what about afterload? So there are conditions that reduce the afterload. The most important condition that reduces the afterload is something called amyl nitrate inhalation, or any vasodilator can reduce the afterload. What are the conditions that increase the afterload? Okay, the most important is isometric hand grip. Okay, isometric hand grip. So that's going to increase the afterload. So Valsalva standing reduces the preload. Leg raising and squatting increases the preload. Amyl nitrate inhalation or any vasodilator you give, that's going to reduce the afterload, even ACE inhibitor ARBs. And if you are going to do isometric hand grip, that's going to increase the afterload, thereby reducing the obstruction, reducing the murmur. Very, very important points, okay, for exams. And another important point is, whenever you increase the contractility also, obstruction will increase. Whenever you increase the contractility, obstruction will increase. So what's going to increase the contractility? Exercise. The most important physiological maneuver that increases the cardiac contractility, exercise. People can say digoxin. Yes, digoxin is going to increase the obstruction by increasing the contractility. That's why digoxin is contraindicated in patients with HOCM. But remember, the most important physiological maneuver that can increase the contractility is exercise. Exercise can increase the obstruction. That is the reason why exercise can cause sudden death in these patients. I hope you get it. So that's all. So I've discussed everything with regards to sudden death in exam, which is a very, very important pointer. Okay. So now coming to the pericardial disorders. So pericardial disorders, they can ask acute pericarditis, they can ask even pericardial effusion and tamponade, but when it comes to exams, they're going to concentrate on the tamponade part. Okay, they're going to concentrate on cardiac tamponade. So everyone knows what is tamponade. It's an acute effusion. Okay, that's going to cause some hemodynamic disturbances. Remember, just the mere presence of fluid around the heart is not tamponade. If you have just fluid around the heart, that is only effusion. If the fluid starts compressing on the heart, if the fluid starts exerting some force on the heart, that is tamponade. Okay. So what are the features of tamponade? Clinically, everyone would have studied. There is something called Beck's triad. So what is Beck's triad? You're going to have jugular venous distension. You're going to have hypotension. And you have muffled heart sounds, or we can call it as distant heart sounds or muffled heart sounds. This is the typical Beck's triad. But remember, there are plenty of other things that the patient can have. Patients can have tachycardia. In fact, it will be very severe tachycardia. Patients can have severe tachypnea, because when you are strangulating the heart, there is no blood flow to the lungs. So that will cause severe dyspnea. And patients can have hypotension and shock. That is already told in the Beck's triad. So patients will have something called as pulsus paradoxus as well. Okay, pulsus paradoxus as well. So what is pulsus paradoxus? Pulsus paradoxus means there is inspiratory fall in the blood pressure by more than 10 millimeters of mercury. Remember, there will be a normal inspiratory fall in systolic blood pressure by at least 3 to 5 millimeters of mercury. But if it is too much, more than 10 millimeters of mercury, that's why called as pulsus paradoxus. The most important cause of pulsus paradoxus in exam is going to be tamponade. So what are the DDs for pulsus paradoxus? Remember, 1/3 of constrictive pericarditis can also produce pulsus paradoxus. 1/3 cases of constrictive pericarditis can produce pulsus paradoxus, but in exam, don't answer this unless and until it's specifically asked for. When they talk about constrictive pericarditis, answer only Kussmaul sign, which is nothing but a absence of respiratory variations in the JVP. You would have studied that inspiratory rise in JVP is called Kussmaul sign, but that's not the exact definition. The exact definition of Kussmaul sign is loss of respiratory changes in the JVP. Normally, JVP should fall during inspiration and rise during expiration. But if that doesn't happen, that is Kussmaul sign. That's what you're going to see in constrictive pericarditis. But 1/3 cases of constrictive pericarditis also can produce pulsus paradoxus. But in exam, first, always think about tamponade. And second, respiratory problems. Severe respiratory problems like acute exacerbation of bronchial asthma and acute exacerbation of COPD. Apart from that, right ventricular MI and acute right ventricular failure, severe pulmonary embolism, so many other things can cause pulsus paradoxus, but at least you need to know this in exam. Tamponade, constrictive pericarditis 1/3 cases, acute exacerbation of bronchial asthma and COPD. All of this thing can produce pulsus paradoxus. Okay, clear? So what is pulsus paradoxus? Fall in SBP by more than 10 millimeters of mercury during inspiration. That is pulsus paradoxus. So this is a typical sign of a tamponade. Remember, tamponade is the clinical diagnosis. If you have compatible clinical presentation, you make a diagnosis of tamponade at the bedside itself. If they ask you investigation of choice, it is simple 2D echo, or otherwise called as transthoracic echocardiogram. Treatment of choice. Remember, There is no need to unnecessarily do pericardiocentesis if the patient is stable. If the patient is having some signs of hemodynamic instability like low BP, or the patient is having jugular venous distension, then you can do something called pericardiocentesis. So how you are going to do pericardiocentesis? You are going to take a needle, insert under the xiphoid process, xiphisternum, at a 30-degree angle and direct it towards the left shoulder. I'll repeat, needle under the xiphoid process, 30-degree angle, okay, insert it and towards the left shoulder. So that is how you do pericardiocentesis. You just suck like 100-200 ml of fluid, the patient will become like very, very better, okay. So that's very important, pericardiocentesis. In a hemodynamically unstable patient, yes, that's the treatment of choice. And what is the typical JVP pattern that you see? You know, jugular venous distension is common. What is the wave pattern that you see? You're going to see something called as deep X descent or a prominent X descent. And you're going to see a blunted Y descent. I'll repeat, deep X descent with blunted Y descent. Characteristic feature of tamponade. Okay, that is why we have a famous mnemonic called as PATAX. So what is PATAX? In tamponade, you're going to see a deep X descent. Whereas in constrictive pericarditis, you will see a deep Y descent. I'll repeat, in constrictive pericarditis, you're going to see a deep Y descent. Remember, in constrictive pericarditis, it's not just deep Y descent. You also see a deep X descent, okay, in constrictive pericarditis. But this deep Y descent in patients with constrictive pericarditis is specifically called as Friedrich sign. Okay, what is that? That's specifically called as Friedrich sign. I'll repeat, deep Y descent in constrictive pericarditis is very special, called by a special name, Friedrich sign. So in tamponade, deep X plus blunted Y. Whereas in constrictive pericarditis, deep Y plus deep X. But what differentiates constriction from tamponade? It's the Y descent. That is the reason why the deep Y descent in constrictive pericarditis is called Friedrich sign. Okay, so this is typical. So what you see in the ECG, whenever you talk about tamponade, you see something called as electrical alternance. So this is a key ECG in exams, electrical alternance. So what is electrical alternance? You are going to see alternating amplitudes of QRS complex. One large, one small, one large, one small, large, small, large, small, large, small. Okay, so that is electrical alternance. So that is what you are seeing in this ECG, and that is suggestive of a tamponade. Okay. Now, let us see some important JVP findings. I think I've discussed this table already in one of my previous sessions, but let me tell you one more time. Okay. So, you know, A wave is due to atrial contraction, C wave is due to isovolumetric ventricular contraction, X descent is due to rapid ejection of the ventricles along with atrial relaxation, V wave is due to venous filling of the right atrium, and Y descent is due to rapid passive filling of the right ventricle. Okay, that is the reason. So if I draw the curves, it's going to be something like this. Okay, it's going to be A, C, X, V, and Y descent. So you know A wave is due to atrial contraction and C wave is due to isovolumetric ventricular contraction. X descent is due to rapid ejection phase along with atrial relaxation. V wave is due to venous filling. Okay, venous filling of the right atrium, and Y is ventricular filling. Especially during the rapid passive filling phase, you are going to get Y descent. So what are the problems that you are going to get in the A wave? So number one, A waves are going to be absent in atrial fibrillation. That's a very, very important point. And when I talk about large A waves, it can be seen in either right ventricular inflow tract obstruction, that is nothing but tricuspid stenosis, or you can see in right ventricular outflow tract obstruction like pulmonary hypertension. Pulmonary hypertension or right ventricular hypertrophy. So inflow obstruction, tricuspid stenosis, outflow obstruction, pulmonary stenosis or pulmonary hypertension. Canon A waves. Whenever you talk about Canon A waves, very large A waves, very, very large A waves, you're going to see in two conditions, AV dissociation and AV NRT. So AV NRT you can remember as PSVT. In colloquial terms, you tend to call it as PSVT. So that is AV NRT or AV dissociation. So when you talk about AV dissociation in exam, only two causes that should come into your mind is VT and a complete heart block. If you talk about a bradycardia with AV dissociation, think about complete heart block. If it's a tachycardia with AV dissociation, think about ventricular tachycardia. Brady with AV dissociation, complete heart block. Tachy with AV dissociation, ventricular tachycardia. Okay, but what will be the type of Canon A waves? Remember, if it's a AV dissociation, this will produce only irregular Cannon waves. Irregular Cannon waves. Irregular Cannon waves. If it's a AVNRT, it's going to produce a regular Cannon waves. If it's AVNRT, it will produce regular Cannon waves. AV dissociation, irregular Cannon waves. AVNRT, regular Cannon waves. Okay, very important point. So there are not much of problems of the C wave generally. If you can see a CV wave in patient with tricuspid regurgitation. So in a patient with severe TR, what are you going to see? You're going to see a smooth CV wave like this. In severe TR, this is what you see. What you're seeing, there will be a CV fusion with no X wave. Okay, X descent will not be there, and there will be a large V wave. So this is the finding in severe tricuspid regurgitation. CV fusion, no X descent, large V wave. So what are the problems of X descent? So you're going to see, I told you, prominent X descent in constitutive pericarditis and tamponade both together. But in tamponade, you'll have a blunted Y descent. Okay. And you're going to see an attenuated X descent in tricuspid regurgitation. I told you, X descent will be lost in tricuspid regurgitation and in patients with right heart failure also. So these are the two most important things that you need to know. So what about V wave? I told you already, the most important cause of large V wave is going to be tricuspid regurgitation. Even though there are plenty of other causes, the most important cause is tricuspid regurgitation. So, you know, V wave is due to venous filling of the right atrium. So something else fills the right atrium. Okay, you're going to get large V wave. So in tricuspid regurgitation, the ventricle is filling the right atrium from down. In ASD, the blood is coming from left atrium to right atrium. In all hyperdynamic states, there will be too much of circulation and blood flow. That's the reason you're going to see large V wave. Y descent. You will see prominent Y descent in constitutive pericarditis. I told you, this is specifically called as Friedrich sign. Okay? Prominent or large Y wave in constitutive pericarditis. And it can be seen in TR and RHF also. And most important cause of attenuated or blunted Y descent. Blunted Y descent is tamponade. But even tricuspid stenosis, RV inflow tract obstruction also is going to produce a blunted Y descent. But the most important cause is tamponade. So these are some of the important JP findings, very commonly asked in exams. In that, what you need to concentrate? Absent A wave, atrial fibrillation, large A wave, tricuspid stenosis and pulmonary hypertension, Cannon A waves, AV dissociation and AVNRT, irregular AV dissociation, regular Cannon waves, AVNRT. Absent X descent, you're going to see in patients with tricuspid regurgitation, and you're going to see, TR especially, you're going to see prominent X descent in tamponade, but also in constitutive pericarditis. You will see large V wave, tricuspid regurgitation and ASD. You see prominent Y descent in constitutive pericarditis, Friedrich sign, also in TR. You see but blunted Y descent in tamponade and tricuspid stenosis. Blunted Y descent is more important in patients with tamponade. Okay, that's a very important point. Okay, Shubhashish Mitra is asking how to differentiate tamponade and ventricular bigeminy in ECG. For that, you need to know what the ECG is showing. See, remember, this is electrical alternance and this is not pulsus alternance. There are many different terms. Okay, pulsus alternance, that is different. In pulsus alternance, what you see is, you see alternating small volume pulse and large volume pulse. That is pulsus alternance, right? That you will see in patients with severe left ventricular failure. Alternating small and large volume pulse, that is pulsus alternance, and you are going to see that in severe left ventricular failure. Alternating small and large volume pulse. But electrical alternance, I told you only the QRS amplitude will change. I didn't say that the pulse amplitude will change. Okay, that is electrical alternance. That is very different. So both are different. And there is something called pulsus bigeminy. So what is pulsus bigeminy? That tends to occur in the setting of ventricular bigeminy. So this is a examination equivalent of a ventricular bigeminy. So what you see in ventricular bigeminy? You are going to see a sinus rhythm, and then you are going to see a premature ventricular complex. Then you see a sinus rhythm. Then you see a premature ventricular complex. Okay, so this is ventricular bigeminy. So here you see a sinus beat and a VPC beat. That itself tells it is ventricular bigeminy. Okay, alternating sinus VPC, ventricular premature contraction. It is ventricular bigeminy. But here you are seeing the normal sinus beat only, but only the QRS amplitude is changing. That is electrical alternance. In case you want to know what is pulsus bigeminy, the sinus beat will be powerful. It will produce a large volume pulse. It's going to produce a large volume pulse. But remember, the ventricular premature contraction beat will produce only a small volume pulse because it is a premature beat. So it's going to produce only a small volume pulse. So now you'll have a confusion how to differentiate between pulses alternans and pulses bigemini. Both are producing alternating small and large volume pulse. How will you differentiate? See, pulses alternans will be regular, whereas pulses bigemini will be irregular. You would have studied in first year physiology. One of the important causes of regularly irregular pulse is pulses bigemini. If you talk about irregularly irregular pulse, atrial fibrillation, regularly irregular pulse, one of the classic examples is bigemini. But pulses alternans is regular, alternating large and small volume pulse. Are you understanding what I'm trying to say? So electrical alternance is different, pulses alternance is different, and pulses bigemini is also different. All are different terminologies, don't tend to confuse with each other. Okay, now coming to important acute aortic syndromes. So what are the important acute aortic syndromes? The most important is aortic dissection. Everyone knows that. Aortic dissection is the most common acute aortic syndrome. Even though there are 3 acute aortic syndromes. One is aortic dissection, second is aortic intramural hematoma, third is you are going to have something called as penetrating atherosclerotic ulcer. Among that, aortic dissection is the most common, occurring in more than 85% cases. So what are the clues in exam for aortic dissection? Number 1, patient will have a chest pain that is going to radiate to the back. Back means where in the back? In the interscapular region, in between the shoulder blades. In the interscapular region, in between the shoulder blades. And they will also tell and mention the quality of the chest pain. So what is going to be the quality of chest pain? Quality of chest pain will be tearing quality, or patients can have ripping quality of chest pain, tearing or ripping quality of chest pain that radiates to the back, interscapular region, aortic dissection. Second, another important clue, there will be abnormal pulse and blood pressure in one limb, or we can say unequal pulse and blood pressure between arms or arms and legs, unequal pulse and blood pressure between arms and legs. That's another important clue in exam. So these are the usual clues. If you take a chest x-ray, what will be the clue in chest x-ray? Chest x-ray is not the investigation of choice, but if you do it, what will you see? You will see mediastinal widening. You're going to see a wide mediastinum because of dissection aneurysm formation. It's a pseudoaneurysm, false aneurysm. So if they ask you what investigation you're going to try in this patient, there are 3 investigations that you can try. One is going to be CT angiogram or a CCT of the chest. Second one, MR angiogram of the chest. Third one is going to be transesophageal echo. What is the investigation that you're going to try? Most commonly performed investigation is CT angiogram. Okay, that's the most commonly performed investigation, but it is time consuming. Okay, and it's not very time consuming, but it needs the patient to be shifted to the CT room. It cannot be done if the patient is unstable. That is why in an unstable patient, if they ask you what you're going to do, unstable patient, what are you going to do? You're going to do transesophageal echo. If the patient is stable, then only you are going to perform a CT angiogram or a MR angiogram. And technically speaking, for a variety of reasons, MR angiogram is actually the gold standard imaging. Okay, MR angiogram is the gold standard. But it's very, very time consuming. That is the reason why we are not going to do MR angiogram commonly. The most common investigation in a stable patient that is done is CT angiogram, which is almost comparable to that of MR angiogram, even though MR is the gold standard. In unstable patient, what we are going to perform is transesophageal echo. That's what you need to know for exams. And you can see this is a picture of a CT angiogram where you can see a sign called as tennis ball sign, but the name is not important. What is important is whether you are able to identify it or not. What you are able to see is a intimal flap. So this central portion is the displaced part of the intima. This is called as intimal flap, and you are seeing 2 lumens. One is called as the true lumen, second is called as the false lumen. Okay, so generally the false lumen will be bigger than the true lumen. Okay, true lumen will be smaller and the false lumen will have lesser contrast compared to that of the true lumen. These are the 2 ways to identify which is true and which is false. So false lumen will have lesser contrast, true lumen will have more contrast, and false lumen will be usually bigger than the true lumen. Okay, now how will you treat? Treatment is based on something called as Stanford classification. So what is Stanford classification? So you're going to divide into Stanford A and Stanford B. Stanford A means ascending aorta is involved. Okay, that is Stanford A. What is Stanford B? Stanford B means ascending aorta is not involved. Ascending aorta is not involved. Which means if both ascending and descending aorta are involved, it is still called as Stanford A only. If both ascending and descending are involved, still it is called as Stanford A. So what about the treatment? Both these patients, the primary treatment is reducing the BP and reducing the heart rate. In both these patients, you have to reduce the BP and heart rate, and the target blood pressure, target systolic blood pressure will be less than 120 millimeters of mercury, and the target heart rate in patient with artery dissection will be less than 60 beats per minute. I'll repeat, target SBP will be less than 120 and target heart rate will be less than 60, and both of these things can be achieved by IV beta blockers. And in the Western textbooks, they would have mentioned the first choice IV beta blocker is esmolol, but we don't have esmolol in India. No company manufactures esmolol. So in India, we commonly use something called as labetalol. That's the commonly used drug. But if esmolol is given in the option, that is the first choice according to the textbooks. Okay. So Stanford A, Stanford B. So for Stanford A, additionally, you need to perform surgery. All patients with Stanford A, ascending aortic involvement, you need to additionally perform surgery. For Stanford B, routine surgery is not recommended. Only in special situations we do. Otherwise, treat conservatively. Stanford A, surgery. Stanford B, generally no surgery. That's all. This is what you need to know. So this is artery dissection and that is done. So coming to respirology sections, you have a very important topic called as venous thromboembolism, which includes two disorders called as DVT and pulmonary embolism. So when you are suspecting a DVT and pulmonary embolism, what investigation you are going to choose? When you are suspecting a venous thromboembolism, what investigation you are going to choose? It depends on something called as Wells probability score. This is something you have to study in the textbooks. Okay, so there is a separate Wells score for DVT and a separate Wells score for pulmonary embolism. So in the Wells probability score, if it comes as low probability, then you can do an investigation called as D-dimer, which has a very high negative predictive value. If the Wells score says that there is a high probability of DVT and pulmonary embolism, you can do some definitive investigation. So what is the definitive investigation? Definitive investigation is either a compression ultrasound or a lower limb venous Doppler, or in textbooks they would have mentioned as compression ultrasound. This is for DVT, or you can do something called as CT pulmonary angiogram. If it's a pulmonary embolism, if the suspicion is pulmonary embolism, you are going to do CT pulmonary angiogram. If the suspicion is DVT, you do a compression ultrasound or a lower limb venous Doppler. If the D-dimer is normal, okay, then you can rule out venous thromboembolism. It is unlikely because it's an investigation with very high negative predictive value. If the D-dimer is elevated, then you need to confirm with a definitive investigation like compression ultrasound or a CT pulmonary angiogram. Very important point. So what is the most important sign of a DVT, deep vein thrombosis? In exam, they will mention calf swelling and tenderness. And most of the time, this calf swelling will be asymmetric in nature. There could be plenty of other signs. You would have said Hohmann sign, Moses sign, but those sensitivities and specificities are very, very low. Asymmetric calf swelling is the most important sign of a DVT, and there could be calf tenderness. And what is the most important sign of a pulmonary embolism? In exam, you need to know something called as unexplained shortness of breath. That's the most important sign of a pulmonary embolism. There will be positive of clinical signs. Patient will complain of breathlessness, but you examine in an acute PE, there won't be any much clinical findings to look for. But the patient will have severe breathlessness and the patient will present with type 1 respiratory failure. That's the key for pulmonary embolism. And some important investigatory findings they will ask in exam. The most common ECG change in a patient pulmonary embolism is sinus tachycardia. The most common change, 95% plus cases will have sinus tachycardia. And it's not only sinus tachycardia, patient will have or might have right ventricular hypertrophy. What is right ventricular hypertrophy? You'll have a large R wave in V1, but you don't have white QRS. Whenever you have a large R wave in V1 with a white QRS, it is right bundle branch block. If you have a large R wave in V1 with no white QRS, generally we tend to make a diagnosis of right ventricular hypertrophy in appropriate situations. Okay, apart from that, patients can also have a tall P wave. Whenever you have a tall P wave like this, it indicates right atrial enlargement. Okay, that is because the blood is not able to move from the right side to the pulmonary artery. That's why right ventricle hypertrophies, right atrium also enlarges. So this is right atrial enlargement. And because right ventricle is not able to pump against an obstructed pulmonary artery, you will also see RV strain pattern. You can see T wave inversions, okay, in multiple leads like V2, V3. All these leads are showing T wave inversions, which are nothing but RV strain. And finally, you have the classic S1Q3 T3 pattern, which is neither sensitive nor specific for pulmonary embolism. So this is the deep S wave, and you have a Q wave that's called Q3, and you have a T wave inversion that's called as S1Q3 T3 pattern. So deep S wave in V1, lead 1, along with Q wave in lead 3 and T wave inversion lead 3 is what we called as S1Q3 T3 pattern. So what are the changes? You're going to see tall R waves, sinus tachycardia, tall R waves in V1 with large P waves, tall P waves in lead 2, P pulmonal, R waves due to right atrial enlargement, and RV strain evidenced by T wave inversions in V1, V2, V3, V4 and all. And you're going to see the classic hallmark S1Q3 T3 pattern. Again, I'm telling it is neither sensitive nor specific for pulmonary embolism. Okay, this is for venous thromboembolism. I told you investigation of choice for pulmonary embolism is a CT pulmonary angiogram. Okay, so what you see here, you can see a thrombus that is occluding the pulmonary artery. This, in fact, this is a kind of a saddle embolus, and you will see contrast filling defects within the pulmonary artery, and that is a sign of pulmonary embolism. So, what is the treatment of any VT? So, if they ask you treatment of choice for any venous thromboembolism, answer is anticoagulation. Anticoagulation is the treatment of choice. In case if anticoagulation is contraindicated, or if the anticoagulation is ineffective, then only you are going to proceed with something called as IVC filters. Okay, treatment of choice is anticoagulation. Okay, in case if anticoagulation is contraindicated or if anticoagulation is ineffective, the patient is having recurrent venous thromboembolism despite adequate anticoagulation use, then you can try something called as IVC filters. Okay, what is the role of thrombolysis? Remember, if a patient is having pulmonary embolism plus systolic blood pressure of less than 90, then you can do thrombolysis. That's it. You can prefer thrombolysis. If the patient is having pulmonary embolism with the systolic BP of less than 90, this is the only indication for thrombolysis right now. So, pulmonary embolism with the SBP of less than 90, perform thrombolysis. Otherwise, no. Okay, going to the next important topic, that is ARDS. So, first of all, you need to know the diagnosis of ARDS. ARDS will be diagnosed with the help of something called as New Berlin criteria. This is something I've discussed already in one of the previous sessions. So, what is New Berlin criteria? Number one, patient will have acute onset of illness. Acute onset means within 7 days, patient should have developed a serious respiratory disease. Second, patient should have a non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema, which means the pulmonary edema that you are seeing should not be explained by cardiac cause. It should not be due to heart failure. Number three, patient should be having bilateral infiltrates in the chest X-ray. Patient should have bilateral infiltrates in the chest X-ray, or maybe in the CT scan also. Number four, patient should have severe hypoxemia. Severe hypoxemia. Severe hypoxemia. What do you mean by severe hypoxemia? The PaO to FiO2 ratio, that's called as PF ratio, or PaO to FiO2 ratio, should be less than 300. If it's less than 300, it will be called as mild ARDS. If it's 200 to 300, it will be called as, if it's less than 200, it will be called as moderate ARDS. And if it's less than 100, it will be called as severe ARDS. And remember, PF ratio should be calculated based on your PEEP. So PEEP should be at least 5 centimeter of water and above. PEEP should be at least 5 centimeter of water and above. So if the PF ratio is less than 300 with the PEEP of at least 5 centimeter of water, then only you can make a diagnosis of ARDS. So don't forget this PEEP. That's very, very important. So this is a typical X-ray that you're going to get in patients in exams if they want you to diagnose ARDS. Remember one more important thing, that the most common cause of ARDS is sepsis, especially gram-negative sepsis causing endotoxic shock. Second most common cause is going to be pneumonia. Second most common cause is pneumonia. So gram-negative sepsis, endotoxic shock is the most common cause. Second most common cause is direct lung injury due to pneumonia. That's the cause of ARDS. And what is the treatment of ARDS? First thing, you need to reverse the cause. Whatever the underlying cause is, you have to reverse that cause. Second, you need to prevent the lung injury. How will you prevent? There should be good ventilator settings. Number one, low tidal volume ventilation. So what is low tidal volume ventilation? So normal tidal volume is somewhere around 8 to 10 ml per kilogram. So this is a normal tidal volume that we set in the ventilators. But if you are suspecting ARDS, then the tidal volume must be 4 to 6 ml per kilogram. Okay, so this is called low tidal volume ventilation. In fact, this is the only thing that has a concrete evidence to say that that's going to improve survival. The only thing that definitely improves survival is low tidal volume ventilation. Low tidal volume. Second, PEEP is very important, but you have to titrate according to the needs of the patient. There is nothing called low tidal volume high PEEP ventilation. PEEP should be titrated based on something called as ACLS Protocol, which is something beyond the scope of the current discussion. Third, you can go for fluid restriction, conservative fluid management. This also has been proven to be efficacious, even though survival impact is not that great. And early use of paralytic agents. Early use of paralytic agents like cis-atracurium or atracurium. Even this has been shown to have some effect, especially in patients who are having ventilator patient dysynchrony. For example, ventilator is doing something, patient is doing something. Ventilator is in the phase of expiration, but the patient is breathing in. In ETC-O2 curve, you will see that as a curar notch or a curar cleft. Okay, that is a sign that the patient is not receiving adequate amount of paralytic agents, and that also tells you that you need to definitely increase the dose of paralytic agents. That also has a good effect, especially in patients who are having ventilator patient dysynchrony. Okay, fine. Finally, fifth one, last but not the least, you need to consider proning for at least more than 16 hours a day. That's very important. So these are the 5 things that have effect in patients with ARDS, but corticosteroids have no effect. Corticosteroids have no effect in ARDS. So don't use glucocorticoids. Morphine, no. I don't know why morphine should be used. Coming to the PFTs. I think in the previous section, I have told you some important pointers on how to approach a pulmonary function testing, but I can tell you some of the flow volume loops here as well. So whenever you see a characteristic coving appearance like this, it indicates an obstructive lung disease. Obstructive lung disease means we are talking about small airways obstruction. I'll repeat, you're talking about small airways obstruction. I'll repeat again, small airways obstruction. You see a coving appearance like this, it is small airways obstruction. So what you're going to see in restrictive lung disease, the shape of the curve will be relatively normal. There won't be coving. First of all, you won't see coving. The shape will be normal, no coving. But the size of the curve will be small. That is because of small FVC. Because of small FVC, the overall size of the curve itself will be small and it will appear as if it is shrunken. So that is restrictive lung disease. And when you talk about large airways obstruction, so these are the flow volume loops of large airways obstruction. So this is the expiratory limb, this is the inspiratory limb. If the inspiratory limb is flattened, so this is suggestive of a variable extrathoracic obstruction. I should say large airways obstruction. Once again, this is an expiratory limb, this is an inspiratory limb. If the expiratory limb is flattened, okay, now you can diagnose a variable or a dynamic intrathoracic large airways obstruction. It's not small airways, large airways. And if you see flattening of both expiratory and inspiratory limbs, this is suggestive of a fixed obstruction. That's suggestive of a fixed obstruction. Okay. Remember, these are curves of large airways obstruction, not small airways obstruction. Small airways obstruction will produce only coving. Large airways obstruction will only produce flattening of one of the expiratory or inspiratory limbs or both. If it's inspiratory flattening, variable extrathoracic large airways obstruction. If it's expiratory flattening, variable intrathoracic large airways obstruction. If it's flattening of both expiratory and inspiratory limbs, it is fixed obstruction. It could be extrathoracic or intrathoracic, but it's a fixed obstruction. It's no longer dynamic and variable. Okay. So I'm just skipping the approach to PFTs because in the previous respirology section itself, I've discussed on the PFTs, on how to approach it. So you can look at that session. So let us move on. So these are some of the important devices that you need to know for exams. They can ask. The first one, simple nasal cannula. Okay, these are oxygen delivery devices. First one is simple nasal cannula. So what's the flow rate? Flow rate is going to be somewhere around 1 to 6 liters per minute. and it can deliver a FiO2 of somewhere around 24 to 44%. Okay, so 24 to 44%. And second, this is a simple face mask, SFM, also referred to as something called as Hudson mask. Okay, simple face mask, also called as Hudson mask. What is the most important thing about this simple face mask or Hudson mask? Okay, you have to minimum give a 5 liter oxygen, minimum 5 liter. So remember, simple nasal cannula, you can give at even 1 liter per minute, no problem, but never give an oxygen flow rate of less than 5 liters per minute in a simple face mask. That's very important. You close the nose and close the mouth and give it a rate of only 2 liters per minute. How the patient will breathe? You should not do that. In a simple nasal cannula, at least patient can breathe through the mouth. But if you close the nose and mouth with simple face mask, how the patient will be able to breathe? Not possible. That's why in a simple face mask, minimum recommendation is you have to start at 5 liters per minute, not less than that. Okay. So now, what is this one? So this one is a very important one. This is NRBM, that is a non-rebreather mask. So the oxygen flow rate will be somewhere around 10 to 15 liters per minute. And what will be the FiO2 that will be delivered? Okay, FiO2 that will be delivered. So theoretically, it can deliver somewhere around 70 to 100% depending on the number of valves. If it's a single valve, 70 to 85%. If it's 2 valves, 85 to 100%. This is theoretically. In theory, it can deliver 70 to 100%. But practically speaking, it is only 60 to 85%. This is practical. Practically, it is 60 to 85% only. Not more than, because of the leak of that oxygen outside and the atmospheric air entrainment. So what is the FiO2 that can be delivered by a simple face mask? It can deliver approximately somewhere around 24 to 40%. Okay, so that's the oxygen that can be delivered by simple face mask, not more than that. So some textbooks will give up to 50%, but ideally it is 24 to 40% only. So this is a Venturi mask. So Venturi mask, everyone knows that. You can see the color coding. So why there is a color coding? Because it delivers a fixed FiO2. So that's why it's also called as a fixed performance device. All the other devices we have seen so far are not fixed performance devices. This is a fixed performance device because of the Venturi principle. There is a controlled air entrainment. That's why you're going to have a fixed FiO2 delivery. That's the biggest advantage of Venturi mask. And it's a high flow mask. It's not a low flow device. It's a high flow device. Even that point is very important. And what is this one? So everyone will call it as AMBU. Everyone will call it as AMBU. But AMBU is not the right name. This is called as self-inflation bag. This is called as self-inflation bag. Self-inflation bag, SIB. That's the right name. AMBU is a company name. Because we have colloquially made to use it like it's not the right name. It's a self-inflation bag. What is this one? This is used in the OT rooms by the anesthetist. AMBU can be used by anyone. It's user-friendly. Even patients' attenders can use it. But this needs expertise. Only doctors and trained people can use it. This is called as flow inflation bags. These are called as flow inflation bags. Flow inflation bags. Which means the bag can be expanded only by adequate oxygen flows. But AMBU can be filled even without any oxygen. It's a self-inflation bag. Everyone knows what is this. This is HFNO, that is high flow nasal oxygen or high flow nasal cannula. So currently it is used as an alternative to CPAP. It can deliver FiO2 from 21 to 100%. And it's a fixed performance device. And it's a high flow device. Okay. It's going to be categorized as a high flow device. Fixed performance device, high flow device, FiO2 21 to 100%. That is HFNO. High flow nasal oxygen or high flow nasal cannula. The biggest advantage is it has a humidifier. It can provide humidified oxygen very easily. Okay, it can provide a warm oxygen, humidified oxygen. Along with that, fixed performance, high flow device, 21 to 100% oxygen can be delivered. Which means simple room air can be delivered or it can deliver 100% oxygen also. It is used currently as an alternative to NIV, like CPAP or BPAP in certain patients. Okay. Now coming to acute exacerbation of COPD. So this is a very common question exam. How will you manage acute exacerbation of COPD? So whenever a patient COPD complains of increasing cough, increasing shortness of breath, or increasing sputum, or all of these things together, plus their usual medications are not giving relief, that is acute exacerbation of COPD. More cough, more shortness of breath, more sputum, but usual medications, whatever they are taking, are not giving relief. That is acute exacerbation of COPD. Clear? Acute exacerbation of COPD. How will you treat a patient with acute exacerbation of COPD? Most common reason for acute exacerbation is infection. And in the infection, if they ask you most common cause, H influenza. H influenza is the most common cause according to the textbooks. And what are the things that you have to do in acute exacerbation? Point number 1, bronchodilators. Give bronchodilators. What bronchodilators? Short-acting drugs. What short-acting drugs? Remember, in COPD, muscarinic antagonists are more effective than beta-2 agonists. Repeat with me. Muscarinic antagonists are more effective than beta-2 agonists, which is the opposite of asthma. Plus or minus, I can use SABA, short-acting beta-2 agonists. Okay. So the best example of short-acting muscarinic antagonists will be ipratropium. The best example of short-acting beta-2 agonist will be levosalbutamol or simply salbutamol or levosalbutamol. In our hospital, we use levosalbutamol very commonly. That's why I wrote that. But anyway, salbutamol, simple example. That's what I'm going to use. Second, you have to give systemic corticosteroids. Systemic corticosteroids. Systemic corticosteroids means you can use either a oral prednisolone oral, or you can use methylprednisolone IV. Suppose if I'm treating as OPD basis, I can use oral prednisolone. If I'm treating as IP basis, I can use IV methylprednisolone. Alright. Number 3. Sorry guys, I'm back. The reason why it got cut is because I think there's a too much overload on the computer and the apparatus, so probably that is the reason why it got quit unexpectedly. I think yes, we are good to go. We can start again. Are you guys there? Give a thumbs up. We are back. We are actually wanting to discuss so many things, right? So we cannot stop here. So I'm going to discuss at least maybe another 1.5 hours. So we are good to go. Okay. All right. Great. So third, after systemic corticosteroids, what are you going to use? You're going to use antibiotics. You can use antibiotics empirically. In case if the patient complains of fever, if the patient is having increased total leukocyte count, WBC count, or high CRP, or if the patient is having new infiltrates in the chest X-ray, imaging, or if the patient is clinically sick, patient is telling too much of sputum, okay, too much of sputum, okay, in that situations and all, it is better that we need to consider starting antibiotics. Remember, the antibiotic choice will depend on what is the local microbiological expertise, but technically, according to the textbooks, macrolides can be started with. To start with, you can start with macrolides, no problem. But technically speaking, the choice of drug should depend on the local culture patterns only. Okay. And what about this one? Next. So you can try something called NIV. Okay, fourth one, NIV, non-invasive ventilation. This is very, very good in patients with acute experimental COPD. So typical NIV that we use in patients with acute experimental COPD is BPAP, that is bilevel positive airway pressure, not CPAP. CPAP should not be used in COPD patients. What are the indications of BPAP? So number 1, I think we have discussed already. pH less than 7.35. Second, PaCO2 more than 45. Okay, so these are the indications for NIV. In fact, if the pH is 7.25 to 7.35, NIV is better. If the pH is less than 7.35, then it's better to avoid NIV. The reason why we avoid NIV if the pH is less than 7.25 is because of high rates of NIV failure. That's why it's better to avoid NIV in that case. So just hold on, I have a small hanging problem. I'll be just back in 20 seconds. Okay, fine, we are back. So NIV, okay. So NIV is very, very important in patients with COPD. And finally, endotracheal intubation. These are the 5-step treatment in patients with acute experience COPD. Number 1, bronchodilation. Second, systemic corticosteroids. Number 3, antibiotics. Number 4, NIV. And number 5, endotracheal intubation. Okay. So finally, in case of severe respiratory failure, we have to go for endotracheal intubation only. So this is the NIV device. In exam, they might ask you this. Okay, this is a typical NIV device. Can you see that? See the NIV device? Can you see? So this is the NIV mask. Okay, and it will have a tubing like this to maintain the positive pressure. It has to be sealed tightly by closing the patient's nose as well as the mouth. Okay, so it could be BPAP or CPAP depending on the device that you are connecting to, but this is a typical NIV device, non-invasive ventilation device. Okay, coming to ILDs, the most important ILDs. Okay, so what is the first image? First image suggests IPF, idiopathic pulmonary fibrosis. Second image suggests sarcoidosis. Third image is also something that is very commonly asked in exams, that is erythema nodosum. That is the third image. So these are very commonly asked in exams. So how to classify ILDs? Interstitial lung disease. How will you classify? Okay. Number 1. So ILD due to known causes. So what are the ILDs that are going to occur due to known causes? Number 1 is occupational ILDs. Very, very important. Occupational ILDs. So what are occupational ILDs? Occupational means it could be hypersensitivity pneumonitis. Hypersensitivity pneumonitis. Okay. Second, it could be pneumoconiosis. So what are the differences between hyperpneumonitis and pneumoconiosis? Hypersensitive pneumonitis is due to organic dust like sugarcane dust or probably cotton industry, something like that. So it is organic dust. Whereas pneumoconiosis is due to inorganic dust like asbestos siliconol. It is due to inorganic dust. Okay, that is pneumoconiosis. Second, drugs can cause ILD. So what are the drugs that can cause ILD? We have plenty of drugs like bleomycin, okay, anti-cancer drug, busulfan, okay, methotrexate, amiodarone, nitrofurantoin. As far as you know, these are the most important drugs that cause ILD. Bleomycin, busulfan, methotrexate, amiodarone, and nitrofurantoin. Number 3, third one, you have ILDs due to CTDs, connective tissue disorders, like for example, rheumatoid arthritis, SLE, Sjogren, okay, scleroderma, systemic sclerosis. So in that, the most important point is rheumatoid arthritis tend to produce a UIP pattern, that is usual interstitial pneumonia pattern, whereas other disorders like SLE, Sjogren, systemic sclerosis and all tend to produce a NSIP pattern, non-specific interstitial pneumonia pattern. But in RA alone, most commonly you will get a UIP pattern. Number 4, last but not the least, apart from connective tissue disorders, smoking related ILDs are there. So what are the smoking related interstitial lung diseases? Number 1 will be something called as RBILD, that's called respiratory bronchiolitis interstitial lung disease. Second one is DIP, that's called as desquamative interstitial pneumonia. And the third one is pulmonary Langerhans histiocytosis, pulmonary Langerhans histiocytosis, pulmonary LCH. In that, in exam, there is a high possibility they will ask about pulmonary LCH only. It typically tends to involve upper lobes. It's a cystic disease. Cystic disease means they can produce recurrent pneumothorax. Apart from ILD, they will have cystic appearance of lung also. Because of the cyst, they can produce pneumothorax as well. And more importantly, biopsy will tell you the diagnosis. In biopsy, you are going to see the malignant Langerhans cells. Langerhans cells. You know, Langerhans cells will be CD1A positive. Okay, and in electron microscopy, they are going to show the characteristic Birbeck granules. Okay, You all know that CD207, that is called as Langerin, even that will be positive. I'll repeat, CD207 called Langerin, that is more specific, that also will be positive. But I don't think in exam they'll ask that. CD1A and Bierbeck granules are going to be more important. These are tennis racket-like granules that you can see. In any smoking-related ILD, even though we use corticosteroids for a short term, the treatment of choice is smoking cessation. I'll repeat, treatment of choice is smoking cessation. And second, we have ILD due to unknown causes. Unknown causes. What are the ILDs due to unknown causes? The number one is going to be sarcoidosis. Sarcoidosis. ILD due to unknown causes. This is also going to come under a special group of ILD called as granulomatous ILD, because they produce non-caseating granulomas. When you talk about sarcoidosis, we have already discussed in detail that you have two syndromes. One is called as Lofgren syndrome and second one is called as Hereford-Waldenstrom syndrome. What is Lofgren syndrome? Patients are going to have bilateral hilar lymphadenopathy. Patients will have arthritis and patients will have erythema nodosum. That is what we call it as Lofgren syndrome. Lofgren syndrome can be managed conservatively because it has excellent prognosis. Excellent prognosis. Lofgren syndrome. Next, we have something called as Hereford-Waldenstrom syndrome. So, what is Hereford-Waldenstrom syndrome? Otherwise called as uveitis fever. So, here the patients will have fever. Patients will be having uveitis. Patients will have parotid gland enlargement. Patients will have parotid gland enlargement. And patients will have seventh nerve palsy as well. It can be bilateral or unilateral, but most often it will be bilateral. Fever, uveitis. Uveitis will be a granulomatous uveitis. And they will have parotid gland enlargement and they will have seventh cranial nerve palsy. This is what we call as Waldenstrom-Hereford syndrome. Okay, both are syndromes of acute sarcoidosis. So, what are the other things that you need to know? Sarcoidosis can affect the pituitary gland also. If it affects the pituitary gland, it can produce central diabetes insipidus. If it affects the kidneys, it tends to produce two things: distal renal tubular acidosis, and it can produce nephrogenic diabetes insipidus also. Which means sarcoidosis is one of the very few conditions that can produce both central as well as nephrogenic diabetes insipidus. That's a very, very important point. Okay, and sarcoidosis in the skin can produce characteristic skin lesions called as lupus perineo. Lupus perineo. Lupus perineo. Fever can occur with Lofgren syndrome, but it is not a part of the classic triad. Okay, so that is from the standard textbooks only. So pituitary, central diabetes insipidus, kidneys, distal RT and nephrogenic diabetes insipidus, and in the skin you typically get lupus perineo. But apart from that, it is a disease that can involve multiple systems in the body, and each and every organ in the body can be involved because of sarcoidosis. And what is the investigation that you're going to do? Patients can have elevated serum calcium because the granulomas contain 1-alpha hydroxylase activity, which can result in hypervitaminosis D, so that you can result in development of hypercalcemia. And patients will have high serum angiotensin converting enzyme. This also will be asked in exams. This is not sensitive or specific, but will be asked in exams. But investigation of choice is going to be biopsy. Biopsy will be the investigation of choice. So how will you do biopsy? You are going to do endobronchial ultrasound guided lymph node biopsy. Endobronchial ultrasound guided lymph node biopsy. That's called E-bus guided lymph node biopsy. You do a bronchoscopy. In that there will be a probe of ultrasound. That's called as endobronchial ultrasound, and with its guidance you are going to do a lymph node biopsy. That's called E-bus guided lymph node biopsy. Okay, where you're going to see something called as non-caseating granulomas. Okay, non-caseating granulomas. Okay, so that's the confirmation. And what will be the treatment? And one more important investigation, which I've told you already in the previous session, is BAL. In the BAL, you see something called CD4-CD8 ratio. If it's more than 2.5, it is also diagnostic of sarcoidosis. BAL CD4-CD8 ratio more than 2.5. Treatment of choice is corticosteroids. You're going to start with prednisolone. That's the first line therapy. Prednisolone. Prednisolone is the first line therapy. That's the treatment of choice. Okay, that's all about sarcoidosis. Second, you have non-granulomatous ILDs. I mean, these are also unknown causes. Sarcoidosis is an unknown cause. Similarly, we have another unknown cause called as IIP. These are called as idiopathic interstitial pneumonias. So, what are the examples of idiopathic interstitial pneumonias? We have something called IPF, that is idiopathic pulmonary fibrosis. Second, we have NSIP, non-specific interstitial pneumonia. Third, we have COP, that's called cryptogenic organizing pneumonia. Fourth one, we have something called AAP, that's called acute interstitial pneumonia. These four are very, very important. In that, I'm not going to discuss each and everything. IPF alone is extremely important for exams. Idiopathic pulmonary fibrosis. So what will be the picture? Age will be more than 50. There is no current known association with smoking. Patient may or may not be a smoker, but it's not important for us. Third, patient will present with chronic, long-standing cough. It will be a dry cough and shortness of breath. It will be a dry cough and shortness of breath. It will be a chronic history. Patient can have associated clubbing, cyanosis and all, but you're going to see a chronic history over months or years together. And investigation of choice for any ILD is going to be HRCT. If they ask you radiological investigation of choice for any ILD, answer is going to be high resolution computed tomography. So typically I'll tell you the picture in HRCT in a while, and what you're going to do as a treatment. If they ask you about treatment is going to be with antifibrotic drugs. So this is called as antifibrotic therapy. So what are the two antifibrotic therapy? One is the TGF-beta inhibitor. That is nothing but pirfenidone. That's called as pirfenidone. And the second one is tyrosine kinase inhibitor. That's called as nintedanib. Tyrosine kinase inhibitor is also called as nintedanib. So one is pirfenidone and second is nintedanib. These are the two approved therapies. Corticosteroids are not indicated. Okay, very, very important point. No corticosteroids. Okay, corticosteroids are not effective in the setting of IPF. So that's another point that you need to know. So age more than 50, no smoking relation, chronic history, they may have clubbing, cyanosis. HRCT is investigation of choice. Treatment is going to be antifibrotic therapy. And if you are doing a biopsy, what is the picture? Biopsy is not required in most cases, but if you are doing a biopsy, you are going to see UIP pattern, that is usual interstitial pneumonia pattern. And more importantly, you have to rule out connective tissue disorders. Only after ruling out CTDs, you can make a diagnosis of IPF, because many connective tissue disorders, including rheumatoid arthritis, can produce a UIP picture, which is a secondary UIP. So that's not idiopathic pulmonary fibrosis. So only when you have ruled out secondary causes like CTD, you can make a diagnosis of idiopathic pulmonary fibrosis. And this is what exactly you are going to see in the CT scan. What you will see? You will see bibasal, which means it's going to typically involve the lower lobes, subpleural, bibasal, subpleural, fibrosis, fibrotic changes. You're going to see fibrosis with honeycombing. These are also called as macrocystic honeycombing. Bibasal, subpleural, reticular densities with fibrosis and macrocystic honeycombing, and plus or minus you can see something called as traction bronchiectasis as well. Traction bronchiectasis as well. You can see all of this. So for example, here you can see there are variable areas of fibrosis. Okay, it's predominantly subpleural and in the lower lobes of the lungs, and you can also see the characteristic honeycombing appearance, and you can also see that some of the bronchus are dilated because of fibrosis. This fibrosis itself will dilate the bronchus and it will look like as if it's bronchiectasis, but it is not. This is what we call as traction bronchiectasis. Traction bronchiectasis. Okay, so these are the ILDs due to known causes, unknown causes. So ILD is over. Now coming to lung cancer. There are some important areas of lung cancer that they will be asking you. So first you need to know the types of lung cancer. Then many times in exam they will ask you about a special type of lung cancer called as Pancoast tumor. Called as Pancoast tumor. So what is the speciality of Pancoast tumor? So it's a kind of squamous cell cancer only, but it is an apical lung tumor. It's going to occur in the apex of the lung. It's an apical lung tumor. This apical lung tumor, which is a typical squamous cell cancer, sometimes can cause plenty of problems. It can involve the brachial plexus, especially the lower roots of brachial plexus, especially the C8T1. That area can be involved, and it can cause wasting of small muscles of the hand, because the small muscles of the hand are typically supplied by T1. So there could be wasting of small muscles of the hand. I'll repeat, wasting of small muscles of the hand. Along with that, patient will have pain in the neck and it can radiate to the arm, and patients will have rib destruction, because this cancer can destroy the nearby ribs. Rib destruction. So brachial plexus involvement, pain, rib destruction. This is a classic feature of Horner syndrome. Because of the sympathetic plexus involvement in the brachial plexus, they can also cause Horner syndrome. It can cause Horner syndrome. It can result in Horner syndrome. So Pancoast tumor means it's a squamous cell cancer in the apex that is compressing the brachial plexus, can cause Horner syndrome and wasting of small muscles of the hand with pain, and they can produce nearby local rib destruction. That is a typical Pancoast syndrome. So when you talk about lung cancer, what is the most important thing with regards to lung cancer? It's the paraneoplastic syndromes. That's more important whenever you talk about lung cancer. So you know what are the types of lung cancer? You have non-small cell lung cancer broadly, and you have small cell lung cancer. Okay, non-small cell lung cancer, and you have something called as, one second, and you have small cell lung cancer as well. Which is more common? Of course, the non-small cell lung cancer variety is going to be the most common. Okay, almost 85% of the lung cancers will be non-small cell type. Small cell lung cancer will be usually 15%. It's not common, but plenty of paraneoplastic syndromes will occur with small cell lung cancer compared to non-small cell lung cancer. So among the non-small cell lung cancer, you are going to have squamous cell cancer, you are going to have adenocarcinoma. You have plenty of other types also, but these two are very important for exams. When you talk about squamous cell, small cell lung cancer, you don't have types, but remember, small cell lung cancer and squamous cell cancer occurs exclusively in smokers. And they are usually central tumors. Central means they occur near the hilar region. Central tumors. When you talk about adenocarcinoma can occur in smokers as well as non-smokers. But remember, adenocarcinoma is the most common lung cancer in non-smoking population. Most common lung cancer in non-smoking population. Okay, and typically it will be peripheral. It will not be central. Most common in non-smoking population, and it will be typically peripheral in nature, not central. So whenever you talk about a central cancer, so you are going to do bronchoscopy guided biopsy. If they talk about a central cancer, the way to sample it is by bronchoscopic biopsy. Whenever it's a peripheral tumor, you can biopsy using something called a CT guided biopsy. This is also an age-old question. Central cancers, bronchoscopic biopsy. Peripheral cancers, CT guided biopsy. That's how it works. And another important point what they can ask is which of the cancers is going to show EGFR mutations. EGFR. That's called epidermal growth factor receptor mutations. Which cancer tends to produce EGFR? We tend to commonly harbor EGFR mutations. Adenocarcinoma. It's a very, very important point. Okay. Adenocarcinoma is the one that commonly shows the EGFR mutations. Epidermal growth factor receptor mutations. Even this is a very important question in exam. Okay. It's a adenocarcinoma. EGFR mutations. Common. Okay. Even though most common mutation in adenocarcinoma is going to be KRAS mutation. Okay. KRAS mutation. But EGFR mutations are commonly seen in patients with adenocarcinoma. Okay, fine. This is done. And what about the paraneoplastic syndromes? PNS. This is very important, isn't it? This is what they will target in exam when it comes to lung cancer. So number one, it can produce endocrine problems. Okay. Second, it can produce skeletal problems, skeletal PNS. And third, it can also produce something called as neurological PNS, neurological paraneoplastic syndromes. So endocrine problems. What are the endocrine problems? Number one, SAADH, syndrome of inappropriate ADH. Syndrome of inappropriate ADH. This is very, very classical of a small cell lung cancer. Second, it can produce ACTH and it can produce Cushing syndrome. This is also very classic of a small cell lung cancer. And third, it can produce hypercalcemia. Hypercalcemia, the reason for hypercalcemia is going to be PTH related peptide. I'll repeat, reason for hypercalcemia is PTH related peptide. And this is from small cell this is from squamous cell cancer, not from small cell lung cancer. Repeat, this is from squamous cell cancer, not from small cell lung cancer. Majority of the paraneoplastic syndromes will be due to small cell lung cancer, but that hypercalcemia is usually due to squamous cell cancer, SCC, not SCLC. So what are the skeletal manifestations? Skeletal manifestations can be clubbing or hypertrophic osteoarthropathy. So this is common in any non-small cell lung cancer, okay, not just squamous cell or adenocarcinoma. But if they typically mention hypertrophic pulmonary osteoarthropathy, this is a manifestation of basically something called as adenocarcinoma. Okay, hypertrophic pulmonary osteoarthropathy. This is common in a patient with adenocarcinoma. I'll repeat. hypertrophic pulmonary osteoarthropathy. So clubbing, it can occur in any non-small cell lung cancer, but if they mention hypertrophic pulmonary osteoarthropathy, it is very classic of a adenocarcinoma. And whenever you talk about neurological manifestations, it is always small cell lung cancer only. SCLC only will produce neurological manifestations. So what are the neurological manifestations? One is going to be your Lambert-Eaton myasthenic syndrome, LEMS, Lambert-Eaton myasthenic syndrome. This is due to anti-VGCC antibodies, anti-voltage gated calcium channel antibodies. It is going to be a close differential for myasthenia gravis, and they can produce peripheral neuropathy. So what are the antibodies that produce peripheral neuropathy? Anti-WHO antibodies can produce peripheral neuropathy, and there is an antibody called as anti-PCA2 antibody that can also produce peripheral neuropathy. And last but not the least, we have an antibody called as anti-CRMP5 antibody that can also cause peripheral neuropathy. In that, the anti-CRMP5 is very important and can be asked in exams. And it can produce cerebellar degeneration. Cerebellar degeneration. So what are the antibodies that are going to produce cerebellar degeneration? The most important antibody is anti-EO antibody. So why anti-EO antibody is important? Because anti-EO antibody exclusively produces only cerebellar degeneration. And apart from that, anti-WHO antibody also can produce cerebellar degeneration. And anti-RE and anti-TR antibody can also produce cerebellar degeneration. So these are the antibodies that generally tend to produce cerebellar degeneration. And it can produce encephalomyelitis. It can affect the brain and the spinal cord together. That's called as encephalomyelitis. Encephalomyelitis can be produced by anti-WHO antibodies. It can be produced by anti-MA1, MA2 antibodies. That's called anti-MA1, MA2 antibodies. And there is another antibody called anti-CRMP5 antibody which can also produce encephalomyelitis. Even though this may not seem very important to you guys, but actually it is extremely important for exams. Many times if they want to frame a little bit of tough questions, this is what they're going to ask in exams. Okay, cerebellar degeneration and encephalomyelitis. In that, anti-EO causing cerebellar degeneration is extremely important. And they can target the hematological complications also. Hematological complications. So what are the hematological complications? Hypercoagulable state. Hypercoagulable state and DIC. So usually this is common in patients with adenocarcinoma. Hypercoagulable state and DIC, because adenocarcinoma secrete mucin that can damage the vascular endothelium and that can produce hypercoagulable state and disseminated intravascular coagulation. Hypercoagulable state and DIC. So coming to emergency medicine, cardiac arrest. Okay, so what are the important things about cardiac arrest? You need to know the ACLS protocol. First, what is this? You have to answer. So what is this one? So this is the paddle position, everyone knows. So this is the anterolateral paddle position. You place on the right side and in the anterior direction, and you place on the left side and in the lateral position. This is the commonest paddle position. Then you can also place in the right anterior and left posterior. Okay, right anterior, left posterior. This is also another important paddle position. So this is how you place the paddles. And on the right side, it's a very common question asked in exams, that is automated external defibrillator. Okay, that is what is asked in exams. So you need to know the AED device also. So how will you assess a patient with cardiac arrest, or how will you approach a patient with cardiac arrest? First, whenever a patient is collapsing in front of you, so what do you do next? You have to always verify the scene safety. So first, scene safety is important. Scene safety is extremely important. The moment you know that the patient is collapsing, go for scene safety. And at the same time, you have to call for help also. Like for example, whatever is the local emergency medical services number, you call that number. So ask for help, call for help, shout for help. So then check for responsiveness. Once you have done the basic checklist, like verifying the scene safety, check for responsiveness. If the patient is responding, no CPR, just observe, wait for the emergency crew to arrive, that's all. If the patient is not responsive, then the next step is to check for pulse and breathing together. Okay, check for the pulse and breathing, even though the pulse is the most important. If the patient doesn't have a pulse, it is equal to cardiac arrest, which means you have to start CPR. Okay, you have to start CPR immediately if the patient doesn't have a pulse. Or if the patient has a pulse and breathing. Okay, patient is breathing also, but patient is having a normal pulse also, or if the patient pulse is felt and patient is breathing normally also, then here just observe, don't do anything again. If the patient is having a pulse but not breathing, patient is having a pulse but the patient is not breathing normally, this is called as primary respiratory arrest, not a cardiac arrest, because the patient is having a pulse, it's not cardiac arrest. So here you are going to try only rescue breaths. Okay, just give rescue breaths here, don't try anything else. Okay, so now you have started CPR. So you have to do CPR till the emergency crew arrives. We are only going to talk about adult CPR. So there are a lot of guidelines for pediatric CPR. But what is the ratio in adult CPR? It's always 30:2. In children, it's a little different depending on 1 or 2 rescuer. But in adults, it's always 30:2. 30 chest compressions to 2 breaths. And what should be the chest compression rate? It should be exactly 100 to 120 per minute. Not more, not less. Okay, 100 to 120 per minute. And the depth of compression should be 5 to 6 centimeter, or we can say 2 to 2.5 inches. That's all. So in case if the patient is having advanced airway, then the rescue breath rate can be somewhere around maybe you can put it around exactly 10 per minute, but only if the patient is having an advanced airway like laryngeal mask airway or endotracheal intubation. Otherwise, you should give rescue breaths at the rate of 30:2 ratio only. So now let us assume the AED arrives at the scene. The emergency crew arrives or automatic external defibrillator somebody is bringing to the scene. So once the AED arrives, follow the instructions and identify what rhythm is going on. So rhythm can be shockable rhythm or it could be a non-shockable rhythm. Rhythm can be a shockable rhythm or it could be a non-shockable rhythm as well. So what are shockable rhythms? Shockable rhythms are pulseless ventricular tachycardia and ventricular fibrillation. VT and VF without a pulse, that is shockable. Non-shockable is pulseless electrical activity and asystole. Asystole means flatline. PEA means anything apart from VT, VF. If she chose a rhythm, that is pulseless electrical activity. So what you will do in a shockable rhythm? In a shockable rhythm, the next step is shock. So what are the 2 types of current that you can use? You can use something called as a biphasic current or a monophasic current. But what is preferred is going to be the biphasic current. Biphasic current is the one that is preferred. And the standard dose is 120 to 200 joules biphasic current. If you are using a monophasic current which is not preferred, in case if you are using, the standard dose is 360 joules. That's the standard dose. So after shocking, don't look at the monitor, do CPR. That's a very, very important point. Okay, don't see the monitor because it's a reflex tendency to see the monitor once you shock to look for the reversal of the rhythm back to sinus rhythm, but don't do that. Avoid the temptation. Go for CPR for 2 minutes. And then only you have to check the rhythm. Okay. If it's PE or asystole, there's nothing you can do. Just continue CPR and check the rhythm. And depending on what is the rhythm, your cycle will continue. Whether it's a shockable or non-shockable, the same cycle will keep continuing, depending on whether it's a shockable rhythm or a non-shockable rhythm. So what are the drugs that you can use in CPR? The most important drug that you can use is adrenaline. This is something that they will ask. Dr. Mutasir Hussain is asking when to intubate if no pulse and no breathing. So remember, if no pulse, cardiac arrest, first is chest compression. That is the most important priority. Intubation also can be done later on because it comes under the airway only. Okay, intubation can be done later on. So once the initial CPR is done, once you feel like at this point you can intubate. So, but chest compressions are the most important. That should be the first. Once you put an advanced airway, then you don't follow the 30:2 protocol. Rather, you give chest compressions at 100 to 120 per minute, and your rescue breath rate will become exactly 10 per minute, which means 1 breath in 6 seconds. That's how it's going to be. So what is the dose of adrenaline? Adrenaline dose is going to be 1:10,000 diluted form of adrenaline. You are going to give 1 milligram dose, and it should be given intravenously. So that's the dose of adrenaline. And whether it can be repeated or not, yes, it can be repeated every 3 to 5 minutes. Every alternate cycles of CPR you can repeat, not a problem at all. And adrenaline can be used for both shockable and non-shockable rhythms. Both shockable as well as non-shockable rhythms. You can use adrenaline, not a problem. So what about amiodarone? Amiodarone, alternative to amiodarone is going to be lignocaine. Alternative is going to be lignocaine. Any one of these drugs can be used, but let us consider amiodarone. Amiodarone dose is 300 milligram first dose. Second dose is 150 milligram. You don't use beyond 2 doses as far as amiodarone is concerned. It should be given IV, of course, as a bolus form. And lignocaine dose will be 1 to 1.5 milligram per kilogram. That's the first dose. Second dose will be 0.5 to 0.75 milligram per kilogram. That's the second dose. So you can repeat one more dose. And amiodarone and lignocaine should be given only in shockable rhythms. I mean, yes, it should not be given in non-shockable rhythms. It's only approved for shockable rhythms. That is for amiodarone and lignocaine. So these are some of the important aspects of cardiac arrest in ACLS protocol. And what are the drugs that's been abandoned? Atropine. In 2005 itself, they removed this. And next is vasopressin. This has been removed in 2010 guidelines. No atropine, no vasopressin. So the drugs that are approved is adrenaline, amiodarone, or alternative to amiodarone is going to be lignocaine. That's it. Done. Coming to some important aspects of acid-base analysis. So at a NEAT PG level or FMG level, the acid-base analysis is going to be very simple and straightforward. So all you're going to see is the pH, you're going to see PaCO2, and you're going to see bicarbonate. So if the bicarbonate is low, PaCO2 is low, pH is low. So what is the inference? Inference is metabolic acidosis. Everyone knows that. If the bicarbonate is high, PaCO2 is also high, pH is also high, inference is metabolic alkalosis. This is the primary. Third, if the PaCO2 is high, bicarbonate is also high, but the pH is low, the inference here is respiratory acidosis. If the PaCO2 is low, bicarbonate is also low, but the pH is high, it indicates a respiratory alkalosis. So this is the table that you need to know. But I don't think you need this table in the first place. All you need to know is just one thing. So see the pH, okay? So whether it is less than 7.4 or more than 7.4. If it's less than 7.4, it is acidosis. If it's more than 7.4, it is alkalosis. That's all. So this patient is having acidosis. Don't mug up the table. But nevertheless, if you see here, the PaCO2 is also high. The bicarbonate is also high. Both are increased because bicarbonate normal value is 24. PaCO2 normal value is 40. So PaCO2 is more than 40 here, 65, increased. Bicarbonate normal value is 24 if it's more than 24 here. So that's also increased. So PaCO2 and bicarbonate both are increased here. So what is the inference? It is respiratory acidosis, but you don't need to know the table for this. Just see which parameter is correlating with the pH. So whether high PaCO2 will cause acidosis or high bicarbonate will cause acidosis. What is going to cause acidosis? Remember, only your high PaCO2 can cause acidosis. High bicarbonate will not cause acidosis. It will cause only alkalosis because the pH is correlating with the PaCO2. My primary diagnosis here is going to be respiratory acidosis. This patient is having a primary respiratory acidosis. But this patient is having a chronic respiratory acidosis or acute respiratory acidosis. For that, I have a trick for you. So, chronic or acute. So, look at the bicarbonate. If the bicarbonate is more than 30, it's very likely to be a chronic respiratory acidosis. If the bicarbonate is less than 30, even though it's increased, if it's less than 30, it's very likely to be an acute respiratory acidosis. In respiratory alkalosis, again look at the bicarbonate. If the bicarbonate is less than 20, it's decreased and it is very low. It indicates a chronic respiratory alkalosis. If it is more than 20, it's reduced. It's less than 24, but if it's still more than 20, it indicates a acute respiratory alkalosis. This is the trick that you need to know. So more than 30 chronic respiratory acidosis, less than 30 acute respiratory acidosis, more than 20, less than 20 chronic respiratory alkalosis, and more than 20 acute respiratory alkalosis. And look at this patient. This patient is having a bicarbonate of 31. Bicarbonate of 31. So you think it's a chronic respiratory acidosis or acute respiratory acidosis? This patient is very likely to have a chronic respiratory acidosis. Chronic respiratory acidosis. So Blue Minion is asking whether compensation formulas are required or not. Honestly speaking, trust me, go to your previous papers and see. At a NEAT PG and FMG level, you don't need the compensation formulas. All you need to know is this much only. Maybe for INA-CT level, definitely you need to know the compensation formulas. There is no doubt about that. For a NEAT PG and FMG level, till now, I don't think they have asked very tough questions on APG. So it's going to be simple and straightforward questions only. So all you need to know is how to find out what is the problem and how to find out whether it is acute or chronic respiratory acidosis. That's it. So now you know and move on. Okay. In all these examples I've given, arrows are moving in the same direction, right? Arrows are moving in the same direction only. But what if arrows are moving in the opposite direction? Like for example, PSU2 is increasing, bicarbonate is decreasing, or PSU2 decreasing, bicarbonate is increasing. Okay? So in that situation, you are going to diagnose a mixed disorder. So whenever arrows are moving in opposite direction, when one component is increasing and the other component is decreasing, close your eyes and diagnose it's a mixed disorder. There's no doubt about it. This is a very, very important point in exam. So arrows moving in opposite direction, mixed disorder. That's it. Don't do anything else. That's mixed. Somebody is asking about anion gap. Yes, anion gap is very, very important for metabolic acidosis patients. If the anion gap is less than 12, it is a normal anion gap metabolic acidosis. If the anion gap is more than 12, it indicates a high anion gap metabolic acidosis. Less than 12 NAGMA, more than 12 HAGMA. And what are the causes of NAGMA? Usually I used to remember by a mnemonic called as RAD. These are the most important causes, even though there are many other mnemonics like Durham and so many other mnemonics are there, but RAD is the simplest mnemonic. It tells you almost all the causes, important causes. R stands for renal tubular acidosis. A stands for Addison disease. And D stands for diarrhea and other gastrointestinal causes. That's all. RAD. RTA, Addison, diarrhea. RTA, Addison, diarrhea. What about NAGMA? I mean, what about HAGMA? High anion gap metabolic acidosis. Okay. So the mnemonic for that is going to be gold mark. Gold mark is the mnemonic for that. So many mnemonics are there. Some people used to remember as mud pails also, but gold mark is the standard mnemonic. G stands for glycols. What glycols? Ethylene glycol, propylene glycol. O stands for oxoproline metabolite. That is usually seen in acetaminophen poisoning. Acetaminophen means paracetamol poisoning. Oxoproline metabolite in paracetamol poisoning. L stands for L-lactic acidosis, L-lactate. D stands for D-lactic acidosis, D-lactate. D stands for D-lactic acidosis, D-lactate. M stands for methanol poisoning. M stands for methanol poisoning. Okay, A stands for aspirin or salicylate poisoning. R stands for renal failure. Don't confuse the RTA here. It's renal failure, uremia. K stands for ketoacidosis. Ketoacidosis can be due to diabetes, that is DK, or it can be due to alcohol, or it can be due to starvation, but most commonly in exam it will be diabetic ketoacidosis, DK. Okay, these are the different causes of high anion gap metabolic acidosis. So now you know. Okay, so now the ABG is done. So in our example, patient is having a high anion gap metabolic. I mean, I don't know the cause of anion. I don't know the anion gap here. Our patient is having a chronic respiratory acidosis. That much we know. RTA type 1 or type 4. Remember, we have three types: type 1, type 2, and type 4 RTA. Okay, type 1 and type 2, type 4, all are normal anion gap metabolic acidosis only. None of the RTA types will produce high anion gap metabolic acidosis. So in AKI, the most important thing that they will ask you in exam is to differentiate between a pre-renal AKI and a acute tubular necrosis. Pre-renal AKI and a acute tubular necrosis. Okay, in AKI, that is what they will ask. So what is pre-renal AKI? Pre-renal AKI is basically due to hypoperfusion to the kidneys, but the tubular function is normal. In acute tubular necrosis, the tubular function is lost. So what are the two most important tubular functions? What are the two most important tubular functions? One is solute reabsorption. Second one is going to be your urinary concentration. Okay, increasing the urinary concentration. These are the two most important tubular functions that we are going to make use of. In pre-renal AKI, it is hypoperfusion only and the tubular function is intact. So they can concentrate the urine. So the specific gravity will be more than 1.020. And they can concentrate the urine. Because of the same reason, urine osmolality will be usually more than 350 to 500. And they can reabsorb the solutes. So fractional excretion of sodium will be less than 1%, which means they can reabsorb solutes better because tubular function is intact. And urinary sodium also will be less than 20. It will not be more. And there is a ratio called as Bun-creatinine ratio. It will be more than 20. That is because they can absorb urea better. So the urea levels will rise. And they can secrete creatinine better as well because tubular secretion of creatinine is intact. So Bun-creatinine ratio will be more than 20. And there's another ratio called urinary creatinine to plasma creatinine ratio, which will be more than 40 as well. Why? Because they can secrete creatinine into the urine well via the tubules. They don't store the creatinine in the plasma. That's why urine to plasma creatinine ratio is more than 40. And what about acute tubular necrosis? So here the tubular function is lost. They cannot concentrate the urine. So specific gravity will be less than 1.010. They cannot concentrate the urine. So urine osmolality will be less than 350. They cannot absorb the solutes. So fractional excision of sodium will be more than 2% technically, but anything more than 1 is abnormal. They cannot absorb the sodium. So urinary sodium will be more than 40. So what about Bund creatinine ratio? Bund creatinine ratio typically will be less than 15 in a patient with acute tubular necrosis. And finally, the urine creatinine to plasma creatinine ratio will be less than 20 in a patient with acute tubular necrosis because they cannot secrete the creatinine. At the same time, they store a lot of creatinine in the blood also. That's why plasma creatinine will rise, but urine creatinine will be low. So the ratio will be less than 20. And in pre-renal AKI, if you examine the urine in the microscope, the urine will be bland. Urine will be bland in the sense you don't see any cast or you don't see any much crystals. Urine will be bland. But in acute tubular necrosis, the urine will show a lot of sediments. Urine will show plenty of sediments, okay, in acute tubular necrosis. Sediments in the sense you will see classic muddy brown cast. That's what they will ask in exam. The classic muddy brown cast that you have studied in pathology. Muddy brown cast, acute tubular necrosis. But in pre-renal AKI, the urine will be bland. Okay. So now we have completed the AKI section also, which is very, very important. And another important area, what I have felt that's very regularly asked in FMG exams is the nutritional part. They will ask the problems due to vitamin deficiencies, isn't it? So first we'll talk about fat soluble vitamin deficiencies. So vitamin A is also called as retinol, retinoic acid, whatever. So what it's going to produce? It's going to produce night blindness. Okay, it's going to produce night blindness and xerophthalmia, and it can also produce something called as keratomalacia. Night blindness, xerophthalmia, and keratomalacia. And what about vitamin D deficiency? Vitamin D deficiency is going to produce two things, rickets and osteomalacia. Rickets and osteomalacia. It's going to produce rickets and osteomalacia. So how will you tell it's a simple vitamin deficiency or a complicated vitamin deficiency? Please don't say cupping, fraying and all. That's very advanced stages of rickets. Whenever you see complicated vitamin deficiency like rickets or osteomalacia, the most important clue in exam is elevated alkaline phosphatase. I'll repeat, whenever you are going to have a complicated vitamin deficiency, you are going to see elevated ALP. That is the earliest sign of a complicated vitamin deficiency like rickets and osteomalacia. Clear? And what about tocopherol? Tocopherol is vitamin E deficiency, right? So usually it doesn't cause much symptoms. It can produce hemolytic anemia. Tocopherol deficiency can produce hemolytic anemia. Okay, that is tocopherol deficiency in newborn infants alone especially. And vitamin K deficiency will produce bleeding diathesis because of poor formation of factors 2, 7, 9, 10, bleeding diathesis. Okay, where the patient will have elevated INR. Okay, so that's the key. Elevated prothrombin time and INR will be there. And what are the problems due to water-soluble vitamin deficiencies? Thiamine deficiency will produce beriberi. Okay, thiamine deficiency will produce beriberi. There are two types of beriberi. Dry beriberi will produce peripheral neuropathy predominantly, ataxia, peripheral neuropathy and all. Wet beriberi will typically produce high output cardiac failure, high output heart failure, high output cardiac failure. So cardiac failure is the key point. Cardiac failure is the key point here in beriberi. So dry beriberi, peripheral neuropathy, wet beriberi, high output cardiac failure. And don't forget Wernicke's encephalopathy. Don't ever forget Wernicke's encephalopathy when you talk about B1 deficiency, thiamine deficiency. So who are the people that are prone for Wernicke's encephalopathy? Number one, alcoholics, alcohol people. Number two, people, pregnant ladies who are having hyperemesis gravidarum. Pregnant ladies are having hyperemesis gravidarum. And third, cachexic patients like malignancy, okay, long-standing cancer pain. These are the three group of patients who are going to develop B1 deficiency commonly. Alcoholics, patients who are having hyperemesis gravidarum, and patients who are having malignancy. So what is the typical triad of Wernicke's encephalopathy? You are going to have confusion, altered mental status. You are going to have ophthalmoplegia. You are going to have ataxia. Treatment of choice, of course, thiamine, but they will ask you which is the first thing to resolve after giving thiamine. So the ophthalmoplegia is the one that resolves first after giving thiamine. Ataxia is the second to resolve. Okay. Finally, confusion will resolve. Okay. First ophthalmoplegia will resolve, then ataxia, then confusion. Okay. This is the order of resolution of Wernicke's encephalopathy. Okay. So what about riboflavin deficiency? Riboflavin deficiency will produce arrhythmia, which can produce local symptoms like mouth sores, okay, mouth ulcers, some small skin changes. That's called as arrhythmia. And vitamin B3 is called niacin. This is something that's very, very commonly asked in exam, that typically tends to produce something called as pellagra. Okay, pellagra. So pellagra is also called as 4D disease. You know what is 4D disease? They produce diarrhea, dermatitis, that Cassell's necklace appearance, dementia, death. Diarrhea, dermatitis, dementia, death. That is pellagra. B3 deficiency, niacin deficiency. And what about B5? Pantothenic acid. Pantothenic acid deficiency will produce paresthesias only, nothing more than that. And B6 is pyridoxine. We all know that pyridoxine deficiency can produce anemia. What type of anemia it's going to produce? It's going to produce sideroblastic anemia. Repeat, that's going to produce sideroblastic anemia. Repeat, sideroblastic anemia. Okay, pyridoxine deficiency. Apart from that, it can also produce peripheral neuropathy. Okay, peripheral neuropathy. And when you suspect pyridoxine deficiency you have to suspect in alcoholics. Okay, pyridoxine deficiency you should suspect in alcoholics, number one, and people who are taking isoniazid treatment for tuberculosis. INH treatment, isoniazid treatment for tuberculosis. For them also, pyridoxine deficiency is very, very common. And remember, pyridoxine deficiency is an important cause of newborn seizures as well. Neonatal seizures. In the newborn children, children also, pyridoxine deficiency can result in refractory seizures. So that is the reason why many neonatologists use pyridoxine as a empirical treatment in patients who are having, in neonates who are having refractory seizures. Biotin deficiency also produces dermatitis only. Okay, biotin deficiency. Folic acid and folinic acid deficiency will produce neural tube defects. Okay, when the mother is having folic acid deficiency, neural tube defects are common, and it also produces anemia. Okay, anemia will be megaloblastic type, not sideroblastic type, megaloblastic anemia. So B12 is also called as cyanocobalamin. So B12 deficiency will produce megaloblastic anemia, and more importantly, neurological complications, neurological problems. It can produce dementia, and it can produce peripheral neuropathy also. So megaloblastic anemia and neurological complications like dementia and peripheral neuropathy. So that is B12 deficiency. Remember, neurological complications will not be seen with folic acid. Neurological complications will not be seen with folic acid deficiencies, only with B12 deficiency. Ascorbic acid deficiency is going to produce the characteristic disease called as scurvy. Everyone knows that, which is going to produce growth problems in children, and they can produce skin changes causing petechiae because of capillary fragility. They can produce bleeding gums. Okay, they can produce joint problems. Okay, they can produce epiphyseal changes. Okay, they can affect the growth also. But more importantly, in exams, they will ask about the bleeding gums. Okay, that is the usual clue to make a diagnosis of scurvy. And that's correct. Many people are commenting on SAC, that is subacute combined degeneration of the cord. That is also a neurological complication of B12 deficiency. That is subacute combined degeneration of the cord. Correct. So this is such an important table. I don't know why, like I've seen like last 3 years, every year they are asking at least one vitamin deficiency for sure. It's a very common thing, like everyone knows this, but still it's very important to discuss. Okay, coming to some of the key environmental issues. Okay, there are two important key environmental issues which I want to discuss. One is heat related illness, second is altitude related illness, and third is cold related illness. When you talk about heat related illness, so usual thing that they're going to ask in exam is differences between a heat exhaustion and a heat stroke. Heat exhaustion and a heat stroke. So that's the difference they're going to ask. How will you differentiate between heat exhaustion and heat stroke? Remember, in heat exhaustion, it's a simple thing. It's a minor problem. So temperature will be less than, the core body temperature will be less than 40.5 degrees Celsius. Whereas in heat stroke, the core body temperature will exceed 40.5 degrees Celsius. It will be 40 to 43 often. And heat exhaustion, The patients may have tachycardia, tachypnea and all, but the vitals will be stable. BP will be normal. And patients will have a normal mental status. Mentation will be normal. Whereas in a patient with heat stroke, the patient will be hypotensive. They might be in shock. And patients tend to have altered mental status as well. Okay, altered mental status as well. And heat exhaustion will not have sweating. I mean, will have sweating. Okay, sweating will be intact in heat exhaustion. In a classic heat stroke, sweating will be lost. The patient will be dry. Sweating will be lost. The patient will be dry. This is very, very important. Okay, temperature less than 40.5, more than 40.5. Normal BP, normal mental status here. Heat stroke will have low BP and altered mental status. Sweating will be intact here in heat exhaustion, whereas in heat stroke, sweating will be lost. But remember, we are talking about a classic heat stroke here. There is something called exertional heat stroke, which I'm not going to talk right now, which is not important, not very commonly asked in NEET, PG and FMGE exams. So classic heat stroke is what is important for exams, and typically tends to affect the elderly population. Old people are more prone for this, and it tends to occur as epidemics. Why it tends to occur as epidemics? Because it tends to occur during the time of heat waves. So heat waves is not going to affect only one person in the community. It's going to affect multiple people. That's why cases will come in clusters. It's going to cause epidemics. So that's how heat stroke will present. So heat related illness over. So how will you treat heat exhaustion? Just hydration. Shift the patient to a cool environment. Give some fluids. That's enough. Heat stroke, you need to initiate cooling. Rapid cooling is very, very important. So rapid cooling is the treatment of choice. Okay. So there are many different types of cooling, active cooling, passive cooling and so on. Active cooling, for example, you can do by injecting cold saline. You can cool down the ringed lactate or normal saline to 4 degrees Celsius and you can inject cold saline. Okay. So that is one way of active cooling. There are multiple ways of active cooling. Okay. So rapid cooling is the treatment of choice. But when you have to stop actively cooling the patient, so when you have to stop actively cooling, this is an exact Harrison statement that you need to know, which is very commonly asked in exams. When you should stop active cooling. Number one, when the patient starts shivering, you have to stop active cooling. Second, when the temperature goes below, temperature reaches around, not less than, around 102 degrees Fahrenheit, you have to stop the active cooling. So when the patient starts shivering, stop active cooling. When the temperature reaches around 102 degrees Fahrenheit, stop active cooling as well. So these are the indications for stopping the active cooling. Okay. So next what they might ask is high altitude pulmonary edema, and this is a high altitude illness. High altitude pulmonary edema and high altitude cerebral edema. So what are the features of high altitude pulmonary edema? Patients are going to present with shortness of breath, hemoptysis. Patients will have crepitations in the lungs and patients will have low SpO2. Okay, so these are the key features of high altitude pulmonary edema. What are the key features of high altitude cerebral edema? Patient will have headache and altered mental status. They can have seizures also, but headache and altered mental status. Do we access the core body temperature? Yes, the ideal way to measure core body temperature is by putting a probe in the pulmonary artery, but that's not always possible. If it's feasible, put a probe in the lower part of the esophagus. Even if that is not feasible, the next best is the rectal temperature. But in the community field settings, the most commonly used method to see the core body temperature is by using the rectal temperature. That is the best. First pulmonary artery, then esophagus. If both are not possible, which is usually the case, go for rectal temperature. That's better. Okay, high altitude cerebral edema. You're going to see headache and altered mental status, plus or minus seizures also. How will you treat a case of high altitude pulmonary edema and high altitude cerebral edema? Number one, okay, oxygen. Oxygen is very, very important because all these problems are due to high altitude and low oxygen. Give oxygen. Plus, I can use something called as temporary hyperbaric chambers. I can use something called as temporary hyperbaric chambers. These are called as gamma bags. Okay, temporary hyperbaric chambers. Hyperbaric pressure chambers. So this is an example of a temporary hyperbaric pressure chamber. Can you see here? So whenever somebody is suffering from serious high altitude related problem, what are you going to do? You're going to put them inside this bag. Okay. What you're going to do is you're going to put them inside this bag and you're going to pump air inside the bag so that you're going to pressurize the bag so that it can mimic as if the patient is in the lower altitude, and you can carry this patient all the way down Okay, these are called as temporary hyperbaric chambers or pressure chambers. Okay, that you can try. Plus, most patients will receive dexamethasone also. Dexamethasone can be tried in almost all patients, not a problem. Okay, you can give. But in high altitude pulmonary edema, additionally you can give non-invasive ventilation. If it's available, you can try NIV like CPAP or BPAP also. Plus, you can try a drug called nifedipine. Okay, in the setting of emergency, you can try something called nifedipine. So these are additional options. But for cerebral edema, this doesn't work. NIV or nifedipine is not going to work. So what is the role of astazolamide? Astazolamide doesn't work for high altitude pulmonary edema as well as for high altitude cerebral edema. For both these things, astazolamide will not work. It will not be used as prophylaxis also. It cannot be used as treatment of pulmonary edema and cerebral edema also, even though people give, but it doesn't work. Prophylaxis only for acute mountain sickness. It will reduce the risk of acute mountain sickness, which is a milder form of HAP in HSE. Only acute mountain sickness risk will be reduced with astazolamide use as prophylaxis. But severe forms like altitude pulmonary edema and high altitude cerebral edema risk cannot be reduced with astazolamide. Very important point. And yes, of course, ultimately the most important treatment is going to be immediate descent, correct? If they ask you the treatment of choice, immediate descent, but many times when they are stuck in the mountains, that may not be feasible. Okay, that may not be feasible. Okay, that's done, that's over. So altitude related problems over. Then what are the cold related problems? In the cold related problems, the most important is the frostbite. Frostbite is basically not just hypothermia, it's a freezing cold injury. That is frostbite. So here is an example of a frostbite. Okay, on the right side. So how the patient will present? Anyone who is exposed to freezing cold, presenting with numbness. Okay, presenting with numbness, or they saying my hand is feeling like a wooden block, my feet are feeling like a wooden block. Immediately you have to diagnose frostbite, suspect frostbite. The first treatment you have to give is rewarming. Rewarming is the #1 treatment of choice for frostbite. And rewarming is excruciatingly painful. The temperature of the rewarming solution is going to be somewhere around 37 to 40 degrees Celsius. Okay, temperature of the rewarming solution. That's the ideal temperature that you have to keep, and it's very, very painful. That is the reason why often we have to give analgesics. Analgesics are very, very important during rewarming. You don't use NSAIDs, but you can use other analgesics. And then if the patient is presenting within 24 hours, you can do MR angiogram. And if there are some vascular changes, local areas of occlusion, you can try IV thrombolysis. IV TPA can be tried if the patient is presenting within 24 hours. The patient is presenting after 24 hours, then you can look at the bone scans, and in India we do FDG PET also to look for the areas of devitalization, and you need to consider amputation. So to see the extent of amputation only, we are doing bone scans and FDG PET. So technically MR angiogram, if within 24 hours, to decide on IV TPA, bone scans if the patient presents beyond 24 hours for the sake of deciding the extent of amputation. Okay, that's it. Okay, these are the important environmental issues that they may ask in the FMGE exams. Very, very important. Okay, at least one question will come from environmental problem. And in the endocrinology, they will ask some important diabetic emergencies. And they will ask treatment of diabetes and diabetic emergencies only. So what are the important diabetic emergencies? We have diabetic ketoacidosis, and we have hyperosmolar hyperglycemic syndrome or HHS, DK and HHS. These are the two things that they may ask as far as diabetic emergency is concerned. So DK typically is common in type 1 diabetes compared to type 2 diabetes, even though, remember, the number of DK cases are more with type 2 because the sheer number of type 2 cases are more. That's why the number of DK cases is going to be more with type 2 diabetes, but the risk of DK is going to be more with type 1 diabetes only. But HHS is usually a complication of type 2 diabetes. It doesn't occur with type 1 diabetes. And remember, diabetic ketoacidosis is very acute in its presentation most of the time, whereas hyperosmolar hyperglycemic state is a subacute to chronic problem. Not chronic really, but subacute problem. It won't be very acute. Why acute? Because DK is due to absolute insulin deficiency. Whereas hyperosmolar hyperglycemic syndrome is due to relative insulin deficiency. It's not due to absolute insulin deficiency. Because of absolute insulin deficiency, the hallmark of decay is ketosis and acidosis. That's the hallmark of decay. If I'm having sugar of 400, it's not decay. If I'm having sugar of 600, it's not decay. If I'm having ketoacidosis, even at the sugar of 250, that is decay. So the ketosis and acidosis is the most important. So you have to prove the presence of acidosis and ketosis. That is very important decay. It's not the case in HHS. That's the very important point. So what is the feature of acidosis? The pH will be less than 7.3. The serum bicarbonate will be less than 18 in patients with diabetic ketoacidosis because of the acidosis. And obviously, clinically, many people are commenting. It will translate into something called as Kussmaul's breathing. Okay, it's going to translate into something called as Kussmaul's respiration, deep and rapid respirations. That is Kussmaul's breathing. Ketosis. Ketosis means you are going to do plasma ketones. Urine acetone is an outdated technique. The Rotheras test and all don't answer in clinical practice. Only plasma ketones we do. Generally, it will be strongly positive, 3 plus or even 4 plus. Strongly positive, just not trace or 1 plus. It will be 3 plus or 4 plus. And typical ketone that we have to measure is beta hydroxybutyrate. That's the best ketone, okay? Beta hydroxybutyrate, best ketone that you can measure, not acetone. Ketosis will be there. And this is the one that clinically translates as something called as that fruity order, okay? Acetone breath. That fruity order is because of the ketosis only. So this is what you need to prove. In patients with HHS, the pH will be more than 7.3. Okay, the bicarbonate will be more than 18. Okay, and patients will not have ketosis. The plasma ketones will be either trace or just 1 plus, nothing more than that. Just trace or 1 plus. Most of the time it will be negative or just a trace or 1 plus. That's all. Nothing more than that. That's why you do plasma ketones. Urine acetone is unreliable. And remember one more thing, that the acidosis will have a high anion gap. It's a metabolic acidosis, and these patients will have a high anion gap, more than 12. Anion gap will be more than 12. That's a very important point. Anion gap will be more than 12. And what is the problem in HHS? Remember, both DKA and HHS patients can have increased serum osmolality, and both can have altered mental status. But remember, HHS patients come to the hospital only because of high osmolality and altered mental status. This is the one that brings the patient to the hospital. Remember, in DKA, the ketoacidosis is the one that brings the patient to the hospital. Because of ketoacidosis only, the patient is coming to the hospital. Okay, maybe additionally they can have altered mental status. But in HHS, the main problem itself is altered mental status and high osmolality only. That is what is bringing the patient to the hospital. So DK, because of the acidosis, the ketoacidosis, patients will have severe abdominal pain, nausea and vomiting. This will be usually not the case in HHS. It can be there, but usually not the case. Abdominal pain, nausea, vomiting, ketone breath, Kussmaul's breathing, all are characteristic of DK. This is what is bringing the patient to the hospital. But in HHS, the primary problem is that altered mental status because of high serum osmolality. That's causing intracellular brain dehydration. That's what is bringing the patient to the hospital. And what will be the CBG? Generally in diabetic ketoacidosis, CBG will be, the capillary blood glucose will be somewhere around 250 to 400. This is the usual CBG that you will see most commonly. But in HHS, the capillary blood glucose will be more than 500 to 600 most of the times. Very, very high levels of sugar. That's typical of HHS. Because of very high sugars, the glucose will increase the serum osmolality. Patient will enter altered mental status. That's how the patient is going to be brought to the hospital. And remember, which has higher mortality? DK or HHS? People can answer. DK or HHS? Which has higher mortality? HHS. Because they present late, subacute, they present with intracellular brain dehydration, and HHS has higher mortality. In fact, the mortality is more than 15% with HHS. DK patients have a less than 3-4% mortality, not that much. HHS has very high mortality. Be careful. And how will you treat? Treatment of any of these hyperglycemic emergencies will be done with something called as FLIP therapy. So that's the mnemonic I use. FLIP. What does FL stands for? FL stands for fluids, I stands for insulin, and P stands for potassium. Okay, FL stands for fluids, I stands for insulin, P stands for potassium and other electrolytes. fluids are the first treatment. Okay, fluids are the first treatment. There's no doubt. What fluid you will use? You'll use either a normal saline or you can use a half normal saline also, depending on certain entities. Technically, how will we choose colloquially is very simple. If the capillary blood glucose is more than 250, we use normal saline. If the capillary blood glucose is less than 250, once the glucose becomes less than 250, we shift to half normal saline. This is a usually, but there are plenty of other ways on how we can choose the fluids, which I'm not going to talk right now. What about insulin? Okay, insulin. Insulin, we use only regular insulin. There's no need to use any analogs. Just use a regular insulin. And remember, insulin is the most important treatment in DK because DK is due to absolute insulin deficiency. People say fluids are the most important treatment. No, insulin is the most important treatment in DK. Fluids are like resuscitation. First choice, yes. If the patient is in shock, dehydration, give fluids, no doubt. First treatment. But insulin is the most important treatment in your diabetic ketosis because without giving insulin, your ketoacidosis will not resolve. Okay. So remember, you are not giving insulin in DK to correct that sugars. Sugar correction is not the primary goal there. The goal for which we are giving insulin in DK patients is to correct the ketoacidosis. Without good insulin, you will not correct the ketoacidosis. That's why insulin is the most important treatment in DK. Fluids are the first treatment. But in HHS, fluids are the most important treatment. Insulin is only an adjunct and an add-on because in HHS, the main problem is altered osmolality and dehydration and altered mental status. So the patient will be terribly dehydrated if it's HHS. So fluids are the most important treatment in HHS, whereas insulin are the most important treatment in DK. Okay, but if the patient is dehydrated, always follow the ABC protocol. First, the vitals are important. Fluids, fluids, fluids. First treatment. Dehydration, shock, fluids. And half NS is contraindicated in shock states. If the patient is hemodynamically unstable, don't use half NS. Please don't use half NS because any hypotonic solution is contraindicated in hemodynamic instability. Or any unstable patient, your hypotonic solutions are contraindicated. So what about potassium? Potassium will be given in almost all patients. So depending on the potassium level, the potassium levels are in the range of 3.5 to 5. I'm going to give insulin, IV insulin and IV KCL both together simultaneously. If the patient is having a potassium of more than 5, then I can give insulin only and I can monitor potassium. Then I can start KCL later on. In case if the serum potassium is less than 3.5, remember starting insulin here can be detrimental. It can result in severe hypokalemia and it can result in more and more problems like arrhythmias. That's why here KCL should be given first. Then after careful monitoring of potassium, then once the potassium becomes more than 3.5, then you add insulin. So 3.5 to 5, insulin and KCL together. More than 5, insulin. Monitor potassium. Later on, you can add KCL if you want. Less than 3.5, first to give KCL. Then once the potassium becomes more than 3.5, then only you are going to start with insulin. That's all. So this is the treatment of some hyperglycemic emergency. That's called as flip therapy. So hope you have understood the importance of hyperglycemic emergency in exam. And now coming to another important endocrinological emergency, that is adrenal insufficiency. Okay, adrenal insufficiency. So one of the key features of adrenal insufficiency and Addison disease is hyperpigmentation. So hyperpigmentation is going to be key feature of primary adrenal insufficiency. Okay, that is Addison disease. So now question comes on how to differentiate between a primary adrenal insufficiency and secondary adrenal insufficiency. Zainab ma'am is there, okay. So she is telling you are working on Midnight Express mode. Maybe I took some inspiration from madam only. Good so madam, I think I have taken some inspiration from Zainab madam and I am taking classes after 12 o'clock. So let the class be like a Midnight Express revision. Okay, fine. So what is the difference between a primary adrenal insufficiency and a secondary adrenal insufficiency? In primary adrenal insufficiency, patient's primary problem is low cortisol. Okay, and this low cortisol is going to increase the levels of ACTH as a reflex. In secondary adrenal insufficiency, the main problem is low ACTH and that is causing low cortisol. and that is causing low cortisol. In primary adrenal insufficiency, the main problem is low cortisol, that is causing increased ACTH, but in secondary adrenal insufficiency, the main problem is low ACTH, and that is what is causing the low cortisol. So basically in secondary adrenal insufficiency, the main problem is pituitary. Okay, pituitary is the problem. Hypopituitarism is the problem in secondary adrenal insufficiency. So what are the other key features of primary adrenal insufficiency? So here the aldosterone levels will be low as well, because aldosterone levels are decreased in patients with primary adrenal insufficiency. You are going to have salt wasting states. Salt wasting states. Salt wasting in the sense the urinary sodium will be high, and because of salt wasting, patient will have hypovolemic hyponatremia. Patient will have hypovolemic hyponatremia because of salt wasting. And patient also will have hyperkalemia, and patient will have normal anion gap metabolic acidosis as well. Patient will have normal anion gap metabolic acidosis as well. So aldosterone levels will be low. But secondary adrenal insufficiency patients will have normal aldosterone levels. Very important point. Patients are going to have a normal aldosterone levels. So in case if it's going to be a normal aldosterone, you don't see salt wasting. You don't see salt wasting. So the classic electrolyte changes you won't see. You won't see hyponatremia. I mean, hyponatremia can be seen, but it's not due to urinary salt wasting. So the urinary sodium will not be increased here. The potassium also will be relatively normal. Okay, and there won't be any normal anion gap metabolic acidosis also. So there will be no salt wasting, no hyperkalemia, no metabolic acidosis. And how you are going to make a diagnosis? Whenever they talk about diagnosis, the investigation of choice in any adrenal insufficiency is going to be ACTH stimulation test. Close your eyes and even blindfolded you can answer that it is going to be ACTH stimulation test only. It's going to be ACTH stimulation test. Okay, ACTH stimulation test. That is the investigation of choice in any one with adrenal insufficiency. So how will you treat? So remember, in primary adrenal insufficiency, you have to give hydrocortisone, which is a kind of replacement to cortisol. Okay, you have to give hydrocortisone. Plus or minus, many times we will be needing fludrocortisone also, which is a mineralocorticoid. So it's not just the cortisol that is the problem, even aldosterone levels are low. That's why you need to give fludrocortisone. Whereas in secondary adrenal insufficiency, because the problem is only cortisol, not aldosterone, only hydrocortisone is enough. Hydrocortisone is enough. Somebody is commenting 24-hour low dose dexamethasone suppression test. Remember, dexamethasone suppression test is an investigation for Cushing's syndrome. Okay, it's to diagnose Cushing's. Here we have to use ACTH stimulation test. It's a provocative testing. Dexamethasone suppression test is for Cushing's, not for adrenal insufficiency. So hydrocortisone only is enough here. Okay, there is no need of fludrocortisone replacement because aldosterone levels are normal in secondary adrenal insufficiency. So how will you manage a patient with adrenal crisis? Suppose let us assume a patient is presenting with adrenal crisis. Patient is presenting with crisis. So how the patient will present? The patient will have some illness, or it could be some stress like surgery, or illness or some other stress like surgery, recent surgery. Yeah, ACTH stimulation test is also called as co-centropin test. That's correct. So illness or surgery, and the patient will have shock that is out of proportion to the severity of the acute illness. So for example, a simple URI causing shock, a simple infection, simple diarrhea causing shock. So simple illness causing a shock that is out of proportion to the severity of the acute illness. That is a key feature for adrenal crisis. And you might have that characteristic electrolyte changes like hyponatremia, hyperkalemia, metabolic acidosis and all. So whenever you talk about adrenal crisis, the first treatment is always IV fluids, NS, because ABCs are very, very important. Okay, your hemodynamics are very important. First IV fluids, normal saline. You have to correct the shock. Then after this, what do you need to do? You need to give corticosteroids. What corticosteroids you have to give? If the patient is a known case of adrenal insufficiency, the patient is a known case. Okay, if the patient is a known case, then I'm going to use hydrocortisone itself. If the patient is not a known case of adrenal insufficiency, I'm going to use dexamethasone. You can ask why I have to use dexamethasone if the patient is not a known case, because If the patient is not a known case, the next step is ACTH stimulation test, because you need to diagnose whether the patient is having adrenal insufficiency or not. So I'm going to perform ACTH stimulation test. So how do you perform? After injecting ACTH, after 1 hour, you are going to check serum cortisol. Hydrocortisone can interfere with the cortisol assays. That is why if the patient is not a known case and if you're planning for ACTH stimulation test, you have to use dexamethasone that doesn't interfere with the cortisol measurements, even if you're doing ACTH stimulation test. That's an important point. Even this is an exam question. So what you have to try. Okay, now you know how to treat an adrenal crisis and adrenal insufficiency case. Now hyperthyroidism. Hyperthyroidism, everyone knows. The most important in exam are only two things. One is Graves' disease and second is decurrence thyroiditis. So first, let me talk about Graves' disease. So Graves patients will have number one, hyperthyroidism. How they are going to present with hyperthyroidism? Hyperthyroidism means they will have increased free T4 and a very much suppressed TSH. They will have high free T4 and a low or a suppressed TSH. Second, they will have extrathyroidal manifestations. Extrathyroidal manifestations. What are the extrathyroidal manifestations? They are going to have Graves' ophthalmopathy. Currently, we don't use the term ophthalmopathy, we use the term orbitopathy. That's the point, orbitopathy. And to diagnose Graves' orbitopathy, the investigation of choice is orbital MRI. Investigation of choice, orbital MRI. Yes, patients can have exophthalmos, patients can have a lot of other signs that you see. The most important is the congestion, chemosis and edema. I'll repeat, congestion, chemosis, edema. These are the important signs of Graves' orbitopathy. And patients can have both unilateral or bilateral, and patients can have asymmetric orbitopathies also. So the exophthalmos can be asymmetric. In fact, the most common cause of unilateral as well as bilateral exophthalmos in the world right now is Graves' disease only. And if they ask you treatment of choice, for moderate to severe cases, corticosteroids, dexamethasone, okay, that's the treatment of choice for moderate to severe case of Graves' orbitopathy. What are the other extrathyroidal manifestations? You can have something called thyroid dermopathy, that's called as pretibial myxedema, that's the old name, where the patient will have pigmented patches in the shin of the tibia, that's very classic site. Or patients can have thyroid acropathy, which is nothing but clubbing and bone changes. Clubbing and bone changes, okay, that is thyroid acropathy. But the most common is Graves' orbitopathy. That's a very important point. So how will you treat the hyperthyroidism? I told you orbitopathy will be treated with corticosteroids, especially if it's moderate to severe or vision threatening. Steroids are the treatment of choice. How do you treat hyperthyroidism? You have many things. You can use anti-thyroid drugs. These are called as ATDs. You have propylthiouracil, you have carbimazole, you have methimazole. Okay, methimazole is the first line drug except in first trimester of pregnancy. So only in pregnant individuals, you all know, in the first trimester, you are going to use propylthiouracil, and in the second or third trimester, you are going to use methimazole. But remember, apart from pregnancy, everywhere else, methimazole becomes the first choice. And the second is radioactive iodine ablation. That's called as RAIA. Third is surgery. But surgery is very rarely performed nowadays for Graves' orbitopathy. We use only radioactive iodine ablation. But what you need to know is contraindications for radioactive iodine ablation. Of course, everyone knows pregnancy is a very, very important contraindication of radioactive iodine ablation. But let us be sensible. Pregnancy, lactation, definite. There's no doubt. Pregnancy, lactation. Apart from that, what are the most important contraindications of radioactive iodine ablation? Second most important is suspected cancer. If you're suspecting a thyroid malignancy, definitely it's contraindicated. You have to proceed with surgery only. Number 3, if the patient is having moderate to severe ophthalmopathy, because this is a very important question in exam, where one of the NEET PG or probably FMGE exams asked like, patient has received some treatment and they had a flare-up of ophthalmopathy. What is the cause? What is the reason? It's actually radioactive iodine ablation. Okay, so radioactive ablation can flare up the ophthalmopathy. Important point, repeat, radioactive iodine ablation can flare up the ophthalmopathy. So in moderate to severe ophthalmopathy, radioactive iodine ablation is contraindicated. You cannot do that. And what are the investigations of Graves' disease or Graves' orbitopathy or any Graves' disease patient? So what they will ask is the TFT. So TFT will show hyperthyroid picture. High T4, low TSH. Second, radioactive iodine uptake, it will be increased, and this increase will be a diffuse and a homogeneous increase. And what about ultrasound? Ultrasound will show increased vascularity. And finally, if they ask you the most specific investigation, answer will be TRAB. That is thyroid receptor antibodies, or you can call it as TSH receptor antibodies. TRAB. These are the most specific investigations. Okay, treatment I told you already. So any one of this you're going to try. Another thing they will ask you is the decoherence thyroiditis. That's very commonly asked in exam. So look at this patient. This patient is having exophthalmos. Okay, and in the radioactive iodine uptake scans, you can see that the thyroid is angry and it's taking so much of tracer, telling it's very hyperactive. In ultrasound, you can see a very, very vascular gland, and that will also translate into bruise in the upper pole of the thyroid gland. Even that is an important point. Upper pole of the thyroid gland is the place where you see thyroid bruise. And you can see like so much of like vascularity. You can see so much of red areas. Those are all highly vascular areas in thyroid gland. And this is an example of a decoherence thyroiditis, or any thyroiditis will produce an absent radioactive iodine uptake only. It will be very, very low. So decoherence thyroiditis. How decoherence thyroiditis will present? Patient will present with pain. That's the most important point. Pain in the neck. Thyroid will be very tender to touch. Patient will have excruciating pain in the thyroid. That's a very important point. And TFT, if you do, the patient will show a hyperthyroid feature. Patient will have high T4, low TSH. So like Graves' disease only. But how will you differentiate? Radioactive iodine uptake will be low. That's a very important point. In any thyroiditis, radioactive iodine uptake will be low only. But the ultimate confirmation will be coming from biopsy, where you will see granulomas. That is why decoherence thyroiditis is also called as subacute granulomatous thyroiditis. I'll repeat, subacute granulomatous thyroiditis. That is decoherence thyroiditis. So painful gland, thyrotoxic picture, okay, with reduced radioactive iodine uptake, biopsy showing granulomas, that is decoherence thyroiditis. Treatment of choice is going to be nothing, conservative management only. You are going to give only NSAIDs and probably some dexamethasone for pain. Apart from that, nothing more than that. Only conservative management. No antithyroid drugs are indicated because the radioactive iodine uptake is low. Why you want to block the gland unnecessarily? So this is a picture of thyroiditis, decoherence thyroiditis. Okay. Now there is something called as primary amenorrhea, which is also very commonly asked in exams. So how will you approach a patient with primary amenorrhea who have not experienced menses at all? So somebody who is coming with primary amenorrhea, what is the first step? Who's going to tell? Yeah, most common cause is Turner syndrome. But the first step that you have to see is secondary sexual characters. Secondary sexual characters, okay? So this is the first step, okay? Secondary sexual characters. Secondary sexual characters means we are predominantly talk about the breast development, okay? Breast development. Whether the patient is having a good breast development or not, we have separate staging system for that. That's called as Tanner staging, okay? Secondary sexual characters, breast examination. Is it there or not? The patient is having secondary sexual characters. Yes. What is the next step? So you have to do ultrasound. In the ultrasound, you have to look for Mullerian structures. You have to look for Mullerian structures. So what is the most important Mullerian structure that you have to look for? It is the uterus. Okay, what is the most important Mullerian structure? It is the uterus. Uterus, that's what you look for. If the Mullerian structures are there, which means uterus is there, then what are the differentials? If the Mullerian structures are not there, then uterus is not there. What are the differentials? The Mullerian structures are there. Okay, which means next step is to look at the anatomy. So how will you see the anatomy? By doing an MRI. MRI is the best investigation, but there are plenty of ways to look at the anatomy. You can do MRI. In MRI, you can diagnose outflow tract obstruction. Okay, this is an abnormal anatomy. Outflow tract obstruction, or MRI can be normal. MRI can be normal, which means there is no outflow tract obstruction. No outflow tract obstruction. No outflow tract obstruction. If this is the case, next step will be to look for FSH, LH, prolactin, and you have to look for hypothalamic and pituitary causes. FSH, LH, and prolactin. Hypothalamic pituitary causes is something that you need to look for. So look for FSH, LH, and prolactin. Very important. So if everything is normal. So in case in ultrasound, if uterus is not there, okay, you are not able to see the uterus. If Mullerian structures are absent in ultrasound, Next ideal step will be karyotyping. Next ideal step will be karyotyping. In karyotyping, if you see a XX karyotype, that is Mullerian agenesis. And that syndrome is called as Mayer-Rokitansky-Kuster-Hauser syndrome. Mayer-Rokitansky-Kuster-Hauser syndrome. Mullerian agenesis. So technically, MRKH means uterovaginal agenesis. Not really Mullerian agenesis. If it's XY, then complete androgen insensitivity syndrome. So if it's XY, you're going to make a diagnosis of complete androgen insensitivity syndrome. Okay. But clinically itself, there will be some clues. If it's MRKH, patient will have normal axillary and pubic hair. That's a very, very important point. Okay, normal axillary and pubic hair. But if it's a androgen insensitivity syndrome, because androgen receptors are defective here, so they will not be able to develop axillary and pubic hair. Axillary and pubic hair will be absent. That's a very important clue, okay, in a complete androgen insensitivity syndrome. So this is how you evaluate. This side is over. That side, if the patient doesn't have secondary sexual characters, what is the next step? You have to look at the height of the individual. Height, see the height. So look at the growth chart and see the height, where the patient is tall or short or normal. So patient can be having a normal height, or patients can be like short stature. Okay, if the patient is short, the next step will be FSH. If the patient is short, next step will be FSH, follicular stimulating hormone. If the FSH is low, it indicates a central cause, like pituitary hypothalamus, because FSH production itself is low. So you have to think about pituitary hypothalamic cause. There could be also growth hormone deficiency, that's why the patient is short. If the FSH is increased, okay, then think about Turner syndrome. So what happens in Turner syndrome? In Turner syndrome, there will be streak ovaries. There will be loss of ovaries. The ovaries will not function properly. That is why reflexly, because of loss of estrogen and other sex hormones, the FSH will increase. It will reach the menopausal level. So that is Turner syndrome. Turner syndrome is the most common cause of primary amenorrhea in the world right now. Turner syndrome is the most common cause of primary amenorrhea in the world right now. Okay. So the patient is of normal height. You know, Turner syndrome, the most important is the short stature only. That's very important. See, what is the typical triad of Turner syndrome? Short stature, streak ovaries, cardiovascular problems. Simple. There are plenty of other issues. They can have like wide, like your carrying angle. Okay, that's called cubitus valgus. They can have webbing of the neck. Okay, they can have so many other problems. But the classic triad is 3. Short stature, they will be average 20 centimeters short compared to their peers. When they complete the puberty, they will be 20 centimeters short. That's a very important point. Harrison statement, 20 centimeters short. Okay. Along with that, they will have streak ovaries, ovarian dysfunction. Along with that, they will have cardiovascular problems. This is the typical triad of Turner. Okay, it's going to affect girls because it's 45X. There's no Y, only 1X. If the height is normal, once again look at FSH. That's the next step. Look at FSH. So if the FSH is low, think about central causes, gonadotropin deficiency. So what central cause they will ask typically here? Kallmann syndrome. That's what they're going to ask. In Kallmann syndrome, there will be an isolated gonadotropin deficiency, but the most important clue in exam will be anosmia. Isolated gonadotropin deficiency with anosmia, Kallmann syndrome. Okay, patient's height will be normal otherwise. If the FSH is high, this is a very important point. It indicates gonadal dysgenesis. Gonadal dysgenesis. PCOD, somebody is answering PCOD. PCOD is a cause of secondary amenorrhea. I repeat, PCOD is a cause of secondary amenorrhea. It's not primary amenorrhea. Okay. So gonadal dysgenesis. Gonadal dysgenesis. It could be either XX gonadal dysgenesis or XY gonadal dysgenesis. So which is the most common? XY gonadal dysgenesis is more common, and it's also called as something called as Swyer syndrome. I'll repeat, it's also called as Swyer syndrome. XY gonadal dysgenesis, where the patient will actually be tall. Okay, patient will actually be tall and they won't have breast development. So which means the gonads have been fried when they are developing as a fetus itself. So in the very early stage of embryonic development itself, they have lost the gonads. Okay, so XY gonadal region is typically called as Swyer syndrome. So this is a very important algorithm. Okay, I don't know how to explain this, but it's so important algorithm. Okay, so it will be so helpful in your exams. So let us look at some of the other endocrine issues, like for example, Kalman syndrome. Sorry, not Kalman, Klinefelter syndrome. Okay, Klinefelter syndrome. This is also something that's very commonly asked in exam. So there are 4 or 5 syndromes that you need to definitely remember in exam. So in fact, for FMGs, I will specially recommend 4 syndromes. One is Turner syndrome. Second is Klinefelter syndrome. Third is Marfan syndrome. And fourth is Ehlers-Danlos syndrome. And maybe if you have time, you can also remember Down syndrome, Noonan syndrome and all. But at least these 4 syndromes, please don't forget for exams. Klinefelter, Turner, Marfan, Ehlers-Danlos. Please. Okay, if you have time, think about Noonan syndrome also and think about Down syndrome also. But whatever these 4 syndromes I told you are extremely important. So what is Klinefelter? It is 47XXY. We all know that. So these patients will be basically males, not females. They will be males. And what is the most common cause? It is non-disjunction. So usually X and Y should separate during meiosis, or 2X should separate. So what happens is, due to meiotic non-disjunction, like there will be one extra X that will be stuck. So in the male sperm, so that when it fertilizes, that's going to cause XXY. That's what is going to cause Klinefelter syndrome. That is due to meiotic non-disjunction. In Down syndrome also, the most common reason is meiotic non-disjunction. Similarly, in Klinefelter syndrome also, the most common underlying reason is meiotic non-disjunction. So what is the feature? Feature will be the extra Y effect. Okay, extra Y effect. Shield chest is a feature of Turner syndrome. And there are plenty of other features of Turner. I'm not denying that. But the classical triad is more important. Okay. So what will be the feature? Number 1, testicular failure. Testicular failure. This is due to the extra Y. That's called as extra X effect. It's not extra Y, extra X effect. Because of that extra X, that will not allow the testicles to develop properly. So the patient will have testicular failure. Typically, first they will have Sertoli cell failure. Then they will have Leydig cell failure. Which means if they ask you first what will be affected, it is the spermatogenesis, because Sertoli cells are important for spermatogenesis. Leydig cells are important for testosterone production. I'll repeat: Sertoli cells, spermatogenesis; Leydig cells, testosterone. First spermatogenesis will be affected, then slowly testosterone production will stop, and because the testosterone production stops, they will develop gynecomastia. And these patients will generally be tall. So due to various reasons, these patients will generally be tall and they will have a lot of hair. They won't have hair loss. They will have a good amount of hair. These are characteristic features. By looking at them itself, we can say why they are going to be tall. Because the fusion of epiphysis doesn't occur earlier at all. It will occur little later because there is no testosterone at puberty. And hair will be good because testosterone is the one that produces that characteristic male pattern hair loss, baldness. So there's not much testosterone, so there is no hair loss. And even face also, they will not have that much of mustache. So the hair will be there in the head, but in the facial hair will be less. The mustache, beard and all will not grow properly for them. That's because of loss of testosterone. That's the reason. So they will have gynecomastia. And apart from that, they can develop a lot of cardiovascular problems. Okay, cardiovascular problems like mitral valve prolapse. That's the most important. Usually it will be asymptomatic and they can develop autoimmune problems like thyroiditis and so on. And there is increased risk of male breast cancer. Increased risk of cancer. So there is 50 times increased risk of male breast cancer in these guys. And there is high risk of mediastinal HCG producing tumors also. 2 cancers can occur at a higher incidence in Klinefelter syndrome. 1, male breast cancer. Please don't forget that. Klinefelter is a very important risk factor for male breast cancer. And second is going to be your HCG secreting tumors. Okay, that is number 2. Mediastinal HCG secreting tumors. These 2 tumors have higher risk. And treatment is testosterone replacement. Like how in Turner syndrome you are going to do estrogen replacement. Likewise in Klinefelter syndrome you are going to do testosterone replacement. That's all. So these are the two important reproductive endocrinology issues that you need to know for exams. Now coming to rheumatoid arthritis management. So remember in exam, the RA management is the one that they're going to ask very commonly. So you know how to diagnose a rheumatoid hand, but one thing I want to say is the most common deformity in a rheumatoid hand is ulnar deviation of fingers. Okay, the most common deformity in a rheumatoid hand is ulnar deviation of fingers. You would have studied boutonniere deformity, swan neck deformity, and so on. But the most common deformity is ulnar deviation of fingers. That's the most common. That is due to subluxation at the MCP joint. And you know the joints that are classically affected, most commonly affected rheumatoid arthritis are going to be the MCP joint. That's the most common. Then you can have involvement of PIP joint, you can have involvement of wrist joint, and in fact knee joint involvement is also very, very common. But the most important thing is what are the joints that are spared in rheumatoid arthritis. The joints that are spared in rheumatoid arthritis is the DAP joint and the thoracolumbar spine. Everyone knows DAP joint is not involved, but very few people know that thoracolumbar spine also will be not involved in patients with rheumatoid arthritis. There will be no involvement of thoracolumbar spine. Cervical spine can be involved, but definitely not thoracolumbar spine. So investigation wise, you know, in exam they will ask only two things. One is rheumatoid factor positivity. Second is anti-CCP positivity. Anti-CCP positivity. So these are called as ACP antibodies, anti-cyclic citrulline peptide antibodies. And we know that anti-CCP antibodies are going to be most specific, more than 95% specificity as far as rheumatoid arthritis is concerned. So how will you treat rheumatoid arthritis? Remember, any acute flare, most of the autoimmune disorders are known for developing acute flares. Any acute flare, you're going to treat with steroids, okay, corticosteroids like prednisolone or methylprednisolone depending on the situation. So what is your preference? So corticosteroids are the most important treatment of acute flares. So maintenance therapy. So long-standing maintenance therapy, you have to use DMARDs. So how you're going to use DMARDs? So the basic therapy, okay, basic therapy is going to be methotrexate. Alternative to methotrexate will be leflunomide. So in some situations we can use both methotrexate and leflunomide together, but generally at a starting point we use either methotrexate or leflunomide. Any one of these drugs is the base. But the backbone of RA therapy is methotrexate. That's why many pharmacology textbooks also give it as a drug of choice, but there's nothing like drug of choice. If the first line drug, it's like a backbone of RA therapy. In any RA DMARD therapy, it is the basic drug. On top of that, if the patient is still not responding properly, you can add other drugs like hydroxychloroquine and sulfasalazine. So this combination is what we call as triple therapy. This combination is what we call as triple therapy. So MTX is the backbone. On top of that, if the patient is not responding, you can add HCQ and sulfasalazine. On top of that, if the patient is still not responding properly, you can use biologicals. Biological drugs. Remember, biological drugs are approved for monotherapy. You can either use in combination with methotrexate, hydroxychloroquine or SAS, or you can use it as monotherapy also, biologicals, not a problem. So what are the biologicals? The first line biological will be anti-TNF alpha drugs. I think that's core pharmacology. I'm not going to discuss. There are 5 anti-TNF alpha drugs: infliximab, etanercept, adalimumab, setrolizumab, and golimumab. I'll repeat: infliximab, etanercept, adalimumab, setrolizumab, golimumab. These are the 5 anti-TNF alpha drugs. In India, we don't have golimumab and we don't have setrolizumab. We have other 3 drugs. Infliximab is available in India, etanercept is available in India, and adalimumab is also available in India. One of the 3 drugs only in India we are going to use. We are going to commonly use. If the pain is very severe, I prefer infliximab, but convenience-wise, adalimumab is better because adalimumab can be given subcutaneously also. Infliximab is IV infusion. Adalimumab is subcutaneous. So adalimumab is more convenient, so I prefer adalimumab in my practice. Okay, anti-TNF alpha drugs. Then anti-IL-6 receptor inhibitor. We have 2 drugs here. One is tocilizumab and second is sarilumab. In India, tocilizumab is available, sarilumab is not available. Okay, so we use tocilizumab, anti-IL-6 receptor, tocilizumab and sarilumab. And we can also use anti-CD20 therapies. So what is anti-CD20? This is rituximab. Commonly what we use is rituximab, anti-CD20. And on top of that, we have some novel therapies also, which you can try. So what are the novel therapies that you can try? These are called as JAK inhibitors. These are oral drugs, not parenteral drugs. What are JAK inhibitors? We have two drugs, tofacitinib and baricitinib. They block the JAK receptor, tofacitinib and baricitinib. These are JAK inhibitors. Or you can use CTLA4 fusion antibodies. CTLA4 fusion antibodies. These are new class of drugs. You have two drugs, abatacept and belatacept. For rheumatoid arthritis, we use belatacept. Abatacept is for transplant patients. Two drugs are there, abatacept and belatacept. These are CTLA4 fusion antibodies. These are some novel therapies which you can try if you want. Okay, so this is the way how you are going to treat a rheumatoid arthritis. Okay. I think I can keep another session slowly over time because I have some more things to discuss and it's already 1:20. So I'll try to close this session for now. And still like 170 people are watching, which is actually very, very heartwarming. So remaining whatever it is, I think we have some 20 slides to discuss. I'll probably try to take forward in the next session. I'll schedule when is the next session, I'll tell you, but it will be before your FMG exam. Don't worry about that. Hopefully this session is useful to you guys and hope like you're going to get as many questions as possible. So if you're going to pass this exam, I'll be really, really happy, so happy. And because I know how students are struggling, especially like when it comes to FMG, like I know it's really like a kind of a hard work and it's a kind of a life or death situation. At least when you're writing NEET PG, you're already having a degree to you, isn't it? And you're working for a higher degree. But when it's an FMG, like I know the pain, I know the hard work that you need to do. And don't even have a degree and you are striving for your basic survival. Okay, that's a very like difficult thing. And always my prayers and my wishes will be there with you guys every time. And I hope like every one of you should succeed well. And I'll try to keep another session. Don't worry about that because it's been already like more than 3.5 hours and my voice is also getting broken. So I'll try to finish off the session now and I'll try to keep another session in some time. And thank you very much, all of you guys, one more time, and wishing you all the very best again and again and again. My heart is always with you. Thank you very much and see you.